Good morning, everyone. Welcome. I would like to ask Dr. Liz Elizabeth Smith, our Executive Director for ASRA, to just open the session.
Hi, everyone. Thank you so much for joining us today for the second annual World Day. As people join, we have a QR code up on the screen here to take a survey. If you wouldn't mind doing that, that would be great. And we'll get started in just a few minutes here. Thank you so much for joining us today.
Thank you, Liz. We have our ASRA Society President, Dr. Eleni Moka, with us. You all know we are celebrating this grand day, and this is the second time we are doing the World Day of Regional Anesthesia 2025. Thanks, Eleni, for making it happen worldwide. It is a festival happening today. Congratulations for this success, and welcome, and please give your message to all of us.
Hello, everybody. Hello to the people that attend, mainly from the United States of America, from North America, I suppose, or from other parts of the world. Happy World Day of Regional Anesthesia and Pain Medicine. Currently, I'm in Paris, from where we control everything that is happening the last days regarding this event. It has been extremely successful. We had projected, I would say, 15,000 participants, but it seems we will go to even greater numbers. Many, many thanks to all of you, to ASRA Pain Medicine for the help, the support, for the very enthusiastic engagement of the activity, to all sister societies that also helped and continue to help till the end of the day. Of course, to the teams behind the scene, ESRA office employees, ASRA employees, and so on. Many thanks to all the faculty, to all of you, for giving your time, your efforts, your engagement to make this event fully successful. Many thanks to WFSA that has endorsed the event as well. I believe that this activity is successful because we managed all together to show that there are no barriers in knowledge spread and education, because we have a common vision and a common mission that is related to taking advantage of the benefits of regional anesthesia, and of course have a pain-free future for all our patients. And as Sebastian, the chair of the activity, has stated, if we are alone, maybe we can go fast, but if we are all together, we can go very far. Many, many thanks, congratulations, and enjoy all the activities. Thank you.
Thank you, Eleni. Congrats once again. Thank you. So today, this is unique. We are doing an exclusive POCUS webinar on behalf of American Society of Regional Anesthesia and Pain Medicine. We all know this is a regional day, but regional anesthesia POCUS are becoming an integral part, is hand in hand. So this is a unique opportunity for everyone to extend beyond regional anesthesia and learn more ultrasound skills. So can everyone see my screen? So we are at the 2025 Second World Regional Anesthesia Day. Thanks for the ASRA Society, and also again for all the sister societies and everyone who is acknowledging and sponsoring this event. So on behalf of ASRA, as I said, we are doing an event from 11 to 12. Please join, continue to join that, and we'll start with our POCUS webinar. This is the first exclusive POCUS webinar for the World Regional Anesthesia Day. So we are thrilled and excited for this. We have a great panel of speakers with us today. I really thank each and everyone for spending your valuable time over the weekend to share your knowledge, expertise with the participants from the worldwide. This is almost like a 525 registrants here. fully packed webinar. So we are all looking forward to learn, listen, and share your expertise. So we have myself, Dr. Hari Kalagara here, and Dr. Rakesh Shandakoppam from Stanford University, California. He'll be talking on the airway ultrasound. We have Dr. Oliver Panzer from Hospital for Special Surgery from New York. He will talk on about lung ultrasound. We have Dr. Nibras Bugrara, he from Albany Medical Center, New York. He will be talking about how to use point of care ultrasound for cardiac arrest, ACLS. This is a must talk to listen. I intentionally kept it in the end so that people are here. If you miss this, you are missing something highlight of this whole webinar. We have 3 eminent female speakers here, part of our ASRA POCUS courses. Dr. Sudipta Sen from UT Health Houston. She'll be talking in gastric ultrasound. We have Dr. Kirti Chigurupati from India joining us to share her expertise in focused cardiac ultrasound. And we have Dr. Sana Khan from UT Health Houston. She'll be talking about abdominal fast ultrasound. Thank you again for all the speakers for joining me today. This is the program we have today. So we'll start with the airway ultrasound. There is a small change in the main program. So just one of the lecture has been moved forward and we adjusted accordingly. Please look at this thing. We'll start with airway, then gastric, lung, take a quick break, cardiac, fast, and easy ALS. So please remain for the whole time and we will try to answer your questions. So I'll be just giving small introduction. What is point of care ultrasound? I am Hari Kalagara from the Mayo Clinic. I have no conflicts of interest except loving the scanning the stuff. I might be a bit more biased because I run the ASRA POCUS courses. I talk very heavily on point of care, but actually those are facts. What is point of care ultrasound? If you are using your ultrasound at the bedside to do anything to the patient, is called point of care ultrasound. It might be a diagnostic, it might be an interventional, anything from simple spinning of the scan to getting an intravascular access or arterial line or anything. So it's not just one area it's limited to, it's anything you can do. As an anesthesiologist, we always talk about ABCD approaches, right? So if you look at the ABCD approach, what can you do with ultrasound? You can do an airway, you can do lungs for breathing, to check the circulation and everything, you can use the cardiac. So you can do from A to Z, that's what I mean. There is no single organ left in the human body that you cannot technically scan or look into. That's how point of care ultrasound is progressing now. Even still, I am a learner in some of the areas. So we can never be experts because it's a growing field and it's vastly expanding. The topics that I highlighted in red today are the 5 to 6 topics we will cover today because I cannot cover the whole POCUS in a single day. We'll cover airway, lung, cardiac, gastric, fast, and resuscitation. So there are many other things coming up. So we'll try to cover them in the future World Regional Anesthesia Days. So this is the core program. We'll concentrate on the ABCDs and mainly on the resuscitation for today. I want to just highlight a few resources that's widely available for anyone who want to learn POCUS. The first and foremost is, we are very proud, is the ASRA POCUS Spotlight. If you are a member of American Society of Regional Anesthesia, or if you go to the ASRA website, put into a POCUS Spotlight or look for the ASRA newsletters, most of the POCUS articles are available there. We publish an article every 3 months, free for everyone, mostly for ASRA members. So please use these resources for your POCUS learning. Even we translated most of them into Spanish. It will be translated into other languages very soon. So this is a very useful POCUS resource from our society named POCUS Spotlight. We also do an introduction to POCUS courses. The next one is in Tampa in September. Please join us. This is a 1.5 day extensive course for POCUS. You'll get the cardiac certification and everything. Amazing course, I shouldn't say because we are doing it. So one of the best courses in the United States in the anesthesia subspecialty that we run. And we all again welcome you to join our 50th annual regional anesthesia meeting, which will be happening this May in Orlando, in my place. Please join this. It is a 50th Golden Jubilee meeting. We don't want to miss the fun, learning, and meeting the experts, and a lot of focus to learn as well. Thank you all, and welcome you all for this webinar again, and a wonderful World Regional Anesthesia Day and Week, and thanks everyone. Anything you want to talk again?
Just thank you for the very kind words, the very nice introduction, and that I feel very, very happy that we can do things together, even if we are in, let's say, a long distance between each other. We can learn from each other, we can teach each other, and we probably are the paradigm that collaboration is the key for a better care for our patients.
Thank you. We have a couple more minutes. I would ask each speaker to just introduce yourself so that we can do the introductions. I'll start with Dr. Rakesh Sondakoppam. Just introduce yourself and move one by one.
Hi, everyone. My name is Rakesh Sondakoppam. I'm currently working at the Stanford University Department of Anesthesia. My areas of interest are mainly regional anesthesia and point of care ultrasound. Thank you for the invitation.
Dr. Panzer.
Hi, good morning or good afternoon, depending on where you are. My name is Oliver Panzer. I'm also an anesthesiologist intensivist with a knack for regional anesthesia. And so I'm an enthusiast for POCUS. I've been lucky enough to kind of teach that with Hari for a while now. And yeah, my main interest is POCUS. It used to be cardiac. Now I'm drifting towards gastric ultrasound in the setting of the GLP-1s and POCUS in resuscitation. And you'll hear a wonderful talk at the end of this.
Dr. Kirti Chigurupati.
Hi, everybody. I'm Dr. Kirti Chigurupati. I'm from India, and I should thank Dr. Hari for this opportunity. I'm a cardiac anesthesiologist. I practice at a cardiac setup in Vijayawada, Andhra Pradesh. My main interest is POCUS, cardiac POCUS, and that's what I've been practicing and trying to teach whenever occasion comes. But thank you so much for this opportunity.
Thank you, Kirti, for joining from India. Welcome. Dr. Sana Khan.
Hi, everyone. It's a pleasure to be here. My name is Sana Khan, and I am at UT Houston, University of Texas in Houston, Texas. And I'm a regional anesthesiologist. I work at one of the largest trauma centers probably in the world. So it's a big privilege to work here. And naturally, we get to use our POCUS skills. I love anything with ultrasound, whether that be regional anesthesia or point of care ultrasound. Thank you for having me.
Thank you, Dr. Sana Khan. So exactly, we are on time, 8:45. So thank you all the speakers once again for being with us. So I would like to start with Dr. Rakesh Sondakoppam. He came from Stanford University. So the only introduction I can say about Rakesh is I call him as an encyclopedia. Anything in regional pain, point of care ultrasound, he knows. Anyone in this, you want to know anything about evidence-based or anything, he is the man to go in our society and for me. Thank you, Dr. Sondakoppam, for joining us, and look forward to listen to your Airway ultrasound. Thank you.
Thank you for the kind introduction, Hari, and you are very kind. So the topic of interest at hand is to provide an update on point of care ultrasound in airway management. Like I said, I am from Stanford University, Palo Alto. I do not have anything significant to disclose related to this talk. So for today, we will brush up on our ultrasound airway scanning techniques and mention how we can optimize our imaging and how to obtain these images. But the crux of my talk will be to convince everyone that why airway POCUS is an essential skill. It is not an option. So it's a skill which every anesthesiologist, every regional anesthesiologist should know. And also we will dwell on few of the future potential uses of point of care ultrasound, like diagnosing sleep apnea and so on and so forth. So most of my topic is derived from many of the salient things said in this POCUS spotlight on airway ultrasound by my very dear friend Sri Kohli from Cleveland Clinic and also Mandeep Singh. I thank ASRA Pain Medicine for making making ASRA as the powerhouse for point of care ultrasound and also the house where everybody can go to it as a resource for anything related to point of care ultrasound. And many thanks to Hari and Stephen Haskins for leading this initiative for ASRA. So a lot of the images for this talk has been taken from the ASRA newsletter, and I highly recommend everyone to read this article to familiarize with airway anatomy. To sum it up, what are the main indications of point of care ultrasound in airway? So the most important one is the first one, is to identify the cricothyroid membrane and the trachea, especially if you are planning for front of neck airway access. You want to be prepared. If you're thinking about it, you should already be planning for it kind of scenario. So either it's you're thinking about a front of neck airway access as a possibility, or you're electively doing a tracheostomy or any other front of neck airway accesses. Cricothyroid membrane identification using ultrasound has significant value. Second use is to identify tracheal placement in the endotracheal tube. That is a successful intubation, and also identifying esophageal intubation. There is a high degree of sensitivity and specificity and reliability depending on where you do the ultrasound scanning. And people may say, oh, I'm good at auscultation, I'm good at other things. Why should I learn POCUS? This is one of the tools in your armamentarium to have in cases where you cannot confirm with the traditional methods. The other uses include evaluation of vocal cords. Sometimes you can use the ultrasound of the trachea to identify the optimal size of the W-lumen tube or even endotracheal tube or tracheostomy tubes. So you can use any of these the utilities from the point of care ultrasound. So going back to brushing on our ultrasound basics and sonoanatomy, there are lots of cartilages in the trachea, but there's only one bone in the front of neck, that is the hyoid bone. And for a sonographer, the main areas of interest include the hyoid bone, the distance between the thyroid cartilage and the hyoid bone, that's the thyrohyoid area, and the thyroid cartilage itself, and then the area between the thyroid cartilage and the cricoid cartilage, that's the cricothyroid area, and then the trachea itself. So you can image either using the transverse midline scan axis, or you can use the longitudinal probe position, either midline or paramedian. If you put it, we will see first on the hyoid and infrahyoid region, because that is where most of the research has been done, and it's mainly used for identifying difficult laryngoscopy and difficult intubation. So if you put the probe transversely directly on the hyoid bone, you'll see a bony shadow. You can scan below the hyoid region, infrahyoid region between the hyoid and the thyroid cartilage to see the thyrohyoid region, and directly on the thyroid cartilage, then on the cricothyroid area, cricoid cartilage, and then on the trachea itself. You can also see the esophagus and so on if you move the probe laterally in the transverse lateral scan. When you put the probe directly on the trachea in the midline, you'll see the cricothyroid area mainly, and you can scan up to see the thyrohyoid area cephalic as well. And you can also slip off of the midline to do a longitudinal paramedian scan for doing airway blocks as well. So coming to the first and foremost infrahyoid scan in the transverse location, you're basically cutting through the hyoid bone like this in this slice. And you basically see a hyoid bone as a white line followed by a dark shadow underneath that. If you slip off of that hyoid bone carded, you'll kind of see a bizarre mixture of soft tissue area. So you can identify the air mucosal interface, and whatever is before the air mucosal interface is the epiglottis. And distance from skin to pre-epiglottis space is one of the predictors of difficult laryngoscopy. And we will talk about that in the next few slides. So you can identify epiglottis and pre-epiglottis space and skin to pre-epiglottis space distance in that area. So this is a nice study done quite a while ago, more than a decade ago. And they saw two parameters which correlated with both difficult laryngoscopy. Both of them are infrahyoid. The one was soft tissue at the level of hyoid bone. If it was more than 1.7 centimeters approximately, that kind of predicted difficult laryngoscopy. But more importantly, if you look at the soft tissue at the thyrohyoid membrane, that is infrahyoid area in the cricothyroid area, thyrohyoid area, if the soft tissue before the epiglottis was more than 2.8 centimeters, it completely separated difficult versus easy laryngoscopies in that study. So you can measure and identify if there is too much soft tissue in the pre-epiglottis space, it can indicate difficult laryngoscopy. When you put it directly on the thyroid cartilage, you'll see the inverted V cartilaginous shadow. Since these are cartilages, they do allow ultrasound waves to pass through, unlike a bone, which reflects it off completely. Underneath the thyroid cartilage, you'll probably see either the true or the false vocal cords. As you can see in this picture, you can see the false vocal cords versus a true vocal cord in the above picture. When you slip off of the thyroid cartilage, you'll see the cricothyroid area. But if you slip off of the cricothyroid area, you'll see the cricoid cartilage itself as an inverted U-shaped cartilage. Interestingly, you will also see the air mucosal interface because these are again cartilages which allow ultrasound to pass through. So between the cricoid, which is more corded, and the thyroid cartilage, which is more cephalad, you can identify the cricothyroid membrane in the transverse sagittal scan. And you put the probe directly on the thyroid cartilage. This is the TACA technique to identify cricothyroid membrane. So you put the probe on the cricoid cartilage, identify it, slip off corded to see the air mucosal interface, slip off even more corded in the corded direction to see the cricoid cartilage. Now come back more cephalad to identify the air mucosal interface, which is the cricothyroid membrane. You can also scan more corded to identify the isthmus of the thyroid, covering the tracheal rings. Onto the left side of the trachea at the level of thyroid isthmus, you will also see the esophagus. When you put the probe longitudinally at the level of hyoid or suprahyoid area, you'll see the base of tongue, the soft and hard palate there, geniohyoid muscle, hyoid bone is a thumb-like black shadow, below which you'll see the pre-epiglottis space, the epiglottis itself. And if you scan laterally in that area, as shown in the bottom figure, you can identify the greater cornu or the bone of the hyoid and the thyroid muscle and the thyroid membrane, and you can inject onto the thyroid, below the thyroid membrane, or inject directly onto the cornu of the hyoid for the superior laryngeal nerve blocks when you're doing airway blocks. One of the key things to remember is you need neck extension. You cannot do that in patients with C collars or decreased submandibular compliance. When you put the probe directly on the midline, you'll often see when you slip off of the thyroid area directly onto the thyroid cartilage, you'll see the thyroid cartilage as the big shadow, followed by the cricothyroid membrane, followed by the cricoid cartilage, which is the biggest pearl in the string of pearls. And you'll see the air mucosal interface underneath that all along. And you can use that to identify and mark the cricothyroid membrane as well. There are two ways. Either you can use the midline approach or the TACA approach. When it comes to airway scanning and measuring the pre-epiglottis space, distance from skin to the hyoid bone, there are a lot of measures which have been used to predict difficult intubation and difficult laryngoscopy. We performed a systematic review which got published recently to look at the utility and the diagnostic performance of these POCUS airway measures to predict difficult intubation. One of the key takeaways from this is we also provided discriminator value and how sensitive and how specific these are, and to compare with the traditional predictors of difficult airway here. As you can see, majority of the traditional predictors have very low sensitivity, but some of them have very high specificity. But of the three we pooled for this purposes of this systematic review, skin to epiglottis distance of more than 2.5 centimeters, that's the pre-epiglottis soft tissue of more than 2.5 centimeter had very good sensitivity as well as good specificity. Hyomental distance ratio had low sensitivity, but slightly higher specificity. Pre-epiglottis to vocal cord ratio had similar sensitivity like skin to epiglottis distance. So things to keep in mind that these can also provide high sensitivity and specificity, more robust performance, and aid in your airway assessment. One of the main uses of POCUS airway is to identify intubation success. If your tube is within the trachea, you'll often see this bullet sign with a big black shadow. Sometimes you can identify the endotracheal tube too, if it is abutting the tracheal mucosa. If it is not, if it is in the esophagus, you'll see the double track sign or double bubble sign kind of a thing. And these are the only two things you need to identify. This is another side-by-side comparison of a bullet sign versus a double track sign. As you can see, one is a success, the other one is a failed intubation. So this is another video demonstration of how you should be seeing esophageal versus tracheal intubation. If the tracheal intubation is successful, you won't see any movement in the esophageal area. It will just be slight amount of movement within the tracheal ultrasound image itself. But if you are passing the tube directly into esophagus, you'll see a lot of soft tissue movement in the esophageal area, and you'll see that expand as well. There are other methods to confirm. You can also put color Doppler on the trachea itself to identify the movement of air or movement of like the sonic shift there in that area. If you see no Doppler signals within the tracheal rings, but on the side soft tissue area, you can also identify esophageal intubation there. Now, for set yourself up for success, where do you really need to scan for the successful intubation really matters, as shown in this study by Steve Oreba and colleagues. They scanned at 3 levels, one at the level of the thyroid cartilage, one at the level of the cricothyroid membrane, and one at the level of thyroid isthmus. And as you can see, so at the level of suprasternal area, almost 100% of tracheal intubations were visualized, but it was lesser and lesser as you move cephaloid with your probe position. So the best place to identify successful and failed intubation is at the suprasternal notch, and I highly recommend it. So what's the learning curve for this? As shown in this study, you just need 2 practice attempts to be almost 100% successful in identifying successful endotracheal intubation versus esophageal intubation. And not only that, in this study, they showed that it had very high sensitivity and high specificity too. And there are a lot of similar studies done for the identifying success of intubation mostly in the emergency scenarios. And as you can see, it has very high sensitivity and high specificity despite pooling this data across multiple studies. And the mean time to confirmation was just 13 seconds. And it had very high accuracy in identifying as well. So one of the common questions they ask is, okay, since you are scanning below the level of vocal cords, can you identify the optimal endotracheal tube cuff location? You can with high sensitivity and specificity too. The caveat is you have to fill the cuff with a saline-filled solution or some kind of liquid for the ultrasound beams to pass through, and you can't do that. It comes with its own downsides of filling the cuff with a non-compressible fluid. So is it useful for endotracheal intubation and identifying successful intubation? The questions you really have to ask is it easy to learn? You just need 2 cases to start learning and doing them in your practice. Is it reliable? Depends on where you do it. So if you're doing at the level of suprasternal notch, yes, it's highly reliable. Is it sensitive? Obviously, as we have seen in the previous slides, yes. Is it very specific? That's a yes too. So why not have this skill in your skill set is a big question. When it comes to front of neck airway access, you see that when you are at the emergency pathway and then you have failed all attempts and you're looking for emergency invasive airway, that's a panic mode. So Difficult Airway Society and many other societies, like airway algorithms, have suggested laryngeal handshake, where if you are suspecting difficult intubation or difficult laryngoscopy, you might as well prepare for front of neck airway access by palpating the cricothyroid membrane, and that's called a laryngeal handshake before you start inducing or trying airway securement. We propose POCUS handshake, either using a TACA or in-plane visualization technique. You can use the thyroid airway, cricoid airline maneuver and come back to the airline and mark it in the midline transfer scan. Or you can use a longitudinal and the transfer scan and mark the cricothyroid membrane. The caveat to this is you need to have the neck in extension to mark it, because when you do the cricothyroid access, you will have the neck in extension as well for cricothyroidotomy. So is there a real value of POCUS handshake? Can be answered if you ask yourself, is it easy to learn again? Is it better at identifying structures than a palpation method or digital palpation? In normal BMI, in abnormal BMI, in altered anatomy, and can you use it for real-time performance of front of neck airway access? And do trainees retain knowledge once learned, or do they lose value if they don't keep practicing? So first question, is there value in POCUS handshake? This was a study from the UK group, which got published in EJ recently, where they put the volunteers in neck extension, did the marking of the cricothyroid area, and then returned them to normal position. And at the end of the procedure, and at the end of the whole study, they asked these people to do the neck extension back again, just to see where the cricothyroid membrane is. So once marked, no matter how you manipulate the neck, but when you're repositioning for front of neck airway access, the markings still hold good true. So you can pre-mark it and use that expeditiously when you are actually needing it to use. How good is palpation versus ultrasound marking? This was a study done in the last 4 or 5 years, where they showed that attempts at palpation was highly successful as attempts with ultrasound marking too. Only thing is, time to identify was far less with the palpation compared to the ultrasound marking. The caveat to this study is they included healthy young young patients with a mean BMI of just 24. So they were otherwise easy anatomy patients. I wish I had all my patients like this so that you don't need ultrasound, but the reality is we have a lot of patients who are coming with difficult anatomy, altered anatomy at times. So what happens with higher BMI? This was a study done where the mean BMI of the patient was 45. And with the digital palpation method, time to mark the cricothyroid membrane was less, but the success rate was less as well. But with the ultrasound method, the time to mark the cricothyroid membrane was significantly longer, but the success rate, you cannot match it with the palpation technique. So the real question is, are you really saving those few seconds? Is it really worth saving those few seconds by not using ultrasound? I don't think so. So once you learn it, is it easy to unlearn it is a question which was answered in this study. And as you can see, when you palpate and mark in overweight patients, they are variable BMI in this study. The palpation was around 40 to 50%, but it was 100% with ultrasound guidance. And trainees retained significant information. So it was still 80% at 6 months interval, whereas it was only 33% with the palpation technique. So you do retain knowledge once you learn it. So it's not hard. Can you do real-time ultrasound guided cricothyroidotomies? This was explored in a study on cadavers, and the failure rate was just 1 out of 21 in this study. So it doesn't take too much time. And the median time to identification of cricothyroid membrane was just 3.6 seconds once you learn it. And the completion of procedure was just 26 seconds. You cannot beat this once you learn the proper technique of bougie guide assisted cricothyroidotomy. This was also confirmed in another study where they saw that ultrasound guided time to needle puncture, time to puncture in the cricothyroid membrane was significantly shorter compared to conventional technique, which showed wide variability in the time to puncturing. So they kind of suggested, which was used by the Difficult Airway Society in their guideline too, that if you have a cannot ventilate, cannot intubate scenario, and if you have an ultrasound immediately available and switched on, you should use ultrasound guided cannula tracheotomy as a first rescue technique. And I highly agree with that statement. There's a common problem when patients have had altered anatomy, tracheal deviation, or previous thyroid surgery. Palpation technique is not good. This is a control with a normal neck anatomy. You're almost 90% sure where the cricothyroid membrane is, but it's 50-50, or even less than 50-50 when you're having previous neck surgery, such as thyroidectomies and so on. So you will see value of point of care ultrasound in this scenario. So coming back to those questions we asked, is it easy to learn? Yes, no question about it. Is it better for identifying structures? Normal BMI, it's as good as palpation. In abnormal BMI, completely beats palpation technique. It's definitely better success rate. In altered anatomy, you'll have better success. Can you use it for real-time performance? Definitely yes. And you do retain knowledge over time. So Difficult Airway Society hence concluded on the role of ultrasound, and it's very good to note that the role of ultrasound in emergency situations should be used if it's available. Airway evaluation using ultrasound is a valuable skill for anesthesiologists, and training for use it is highly recommended even by this 2015 guidelines. This is like almost 10 years ago, which Difficult Airway Society recommended. So I don't see why we won't pick up on these skills and keep using it in everyday practice. Because if you are using it when you really need it, you're usually looking at it and wondering what you're looking at, or you may use it wrongly and cause more harm too. So unless you learn and master it, you're not going to use it when you actually need it. The other uses include sizing the endotracheal tubes or tracheostomy tubes, or even using double lumen tube sizes. As you can see in this pediatric study, they used the so they used the size at the level of cricoid cartilage, because the subglottic area is the narrowest area. So they kind of measured that optimal distance and then used the ultrasound information in 23 patients, whereas they used the conventional sizing method in the other group. And as you can see, the total complication rate was significantly less with the ultrasound group, including the major complications like stridor. The other uses are if you are working with an ENT surgeon and they are doing front of neck access, or if you are performing needle cricothyroidotomy or percutaneous tracheostomy, you may want to use ultrasound to pre-scan and see if there is any vasculature in your way. As you can see in this illustration of frog eye, with release of pressure, you'll see the frog eye come into being. But also, Dr. Kalagara sent me this nice article yesterday when I was discussing with him. This was a case report of a high riding innominate artery, which you could not have identified if not for the POCUS exam. So this is the vocal cord at the level of tracheal cartilage. If you slip slightly off of the tracheal cartilage, thyroid cartilage, you'll see this big hypoechoic structure. And when they put the color Doppler on, that showed it as high riding innominate artery. This will be devastating if you're doing front of neck access. There's also innovative uses. You can use ultrasound guided crack pressure on compressing the esophagus during intubation on the left side of the trachea. But also, we haven't talked much about the suprahyoid area. So this was a very well done systematic review by Mandeep Singh and colleagues from Toronto group, which kind of looked at various parameters of the suprahyoid region and look whether they can predict the possibility of obstructive sleep apnea. Because sleep apnea is dynamic, they also looked at dynamic and static measures being done in studies. These were not necessarily limited to surgical cohorts, and they found that resting tongue thickness, distance between lingual artery, tongue base thickness, and neck circumference, and retropalatal diameter have some promise, but it should be validated in surgical cohorts. Maybe the combination of them makes more sense in detecting sleep apnea. As you all know, sleep apnea is very underdiagnosed in the perioperative population. So we kind of finished this observational study in patients who had previous diagnosis of sleep apnea and had a sleep study done in the last 4 years before they were enrolled. And we measured various parameters in this study, including the tongue base thickness in the sagittal and coronal plane, upper airway length, and skin to hyoid distance, distance between lingual arteries. We also measured the geniohyoid muscle thickness. We also measured the skin, like I said, skin to hyoid distance here. And also we measured the retropalatal diameter, retroglossal diameter, and also the upper and transverse diameter of the pharynx. And we also measured the lateral pharyngeal wall thickness as well. And when you, I'm not going to present all the data here, but the take-home message from our study was that neck circumference really correlated with the apnea-hypopnea index. That's the severity of sleep apnea. None of the POCUS measures had good association with the severity scores. That's the AHI. But POCUS had good, some of the POCUS measures had good association with stop bank scores, like tongue cross-section area, retropalatal diameter, distance between lingual arteries, and geniohyoid muscle thickness. So POCUS has more value as a screening tool than as a diagnostic tool for severity, in our study at least. And maybe that's what it is for, because stop bank is sometimes subjective. Many times you don't know whether patients have witnessed apnea and so on and so forth. So this is one more tool to identify the possibility of sleep apnea in your patient. At the end of my talk, I would like to conclude by saying airway POCUS is a very valuable skill to not only assess and manage airway, it may have some utility in predicting difficult airway or difficult intubation and difficult laryngoscopy. The biggest take-home messages from today's talk, if any, is you will never regret learning airway POCUS, especially when it comes to identifying intubation success or pre-marking cricothyroid membrane, where POCUS should be the way to identify cricothyroid area. The caveat to all this is your POCUS should not interfere or delay management of the airway. So it should all be well planned and should be part of your workflow every day. Thank you, ASRA, and thanks, Hari, for organizing this conference and giving me this wonderful opportunity to share my thoughts on the topic.
Thank you, Dr. Sandakopam. I had never listened to a 30-minute airway ultrasound lecture. So fascinating and amazing. Thank you, Dr. Sandakopam. And look forward for your study results, which you have done on the OSA patients. I think because you are maybe not available because of your on-call commitments, there is one question I will like to answer you. What about the evaluation of vocal cords mobility in suspicion of recurrent laryngeal nerve palsy using airway ultrasound?
Yeah, that's a very valuable tool. I think people have used it in identifying vocal cord mobility before and after intubation, or if there's any neck surgeries. The key to that is the probe mobility. It's a very easy to lose view, especially the true vocal cord view. And also, you have to ask the patient to vocalize, or you have to see the vocal cord movements with respiration. So it's very harder to maintain the view, but it's not impossible. The other thing to keep in mind is you have to have a pre-scan and a post-scan. So you have to identify at baseline for you to have utility and documentation.
Excellent. One more question, Dr. Sandakoppam. How do you address the issue of pre-marking and patient positioning changes with the intubation process? I don't understand the question really well. He is one of our POCUS experts from Toronto, Xavier Kubilos. He's asking. So maybe I was thinking, how do you differentiate one lung or versus mainstem intubation or something like that? I was thinking.
Yeah, the lung ultrasound is more useful in that.
More useful, yeah.
If it's come to pre-marking for the cricothyroid membrane, always do it in the neck extension. That is the final position where you want to do the cricothyroidotomy. That is the position in which you mark it, and then you can change the neck position.
Excellent. He's asking about the cricothyroid membrane. Excellent. What is your take on airway ultrasound for airway blocks, Dr. Sandakoppam?
I did not have too much time to present on airway blocks, but there is a couple of low sample size studies done in awake intubation where they have done external laryngeal nerve block using ultrasound guidance compared to spray as you go technique. And they showed much better intubation conditions and patient comfort and the operator conditions comfort too in those studies. So there's definitely better success rate with your airway blocks, especially the external laryngeal nerve block with your POCUS guidance.
Excellent. Thank you, Dr. Sandakoppam. You took all the time. So I will let the audience type Q&A. We can answer them later on based on the airway. Thank you very much. I'm telling you. So I am a little bit skeptical about the airway ultrasound among the POCUS. Today, you made me believe airway is more important than anything else.
Yes, it is undoubtedly one of the crucial components, essential skill for every anesthesiologist. Thank you.
Thank you. I would like to invite our next speaker, Dr. Sudipta Sen. She's from University of Texas Health from Houston. She is one of our key members for our ASRA POCUS courses. The main introduction and the thing I can give about her is she is one of the first one of the many ones who has done a study on gastric ultrasound for GLP-1 drugs published in JAMA. So happy to have her to share her gastric ultrasound experience with her. Dr. Sen, this is all for you.
Thank you, Hari, for that kind introduction. I hope you all can see my slides as a slideshow.
Yes.
Perfect. Okay. So I'm Sudipta Sen. I am from University of Texas here at Houston. I am in charge of the orthopedic anesthesia division. I'm a regional anesthesiologist by training, and I love everything POCUS. I have nothing to disclose, which I guess is a good thing. My learning objectives by the end of the session is to ensure that the participants that are attending the session currently can give me the indications for the gastric ultrasound. They can walk through all the steps that are required to actually acquire the optimal image and how exactly they're going to interpret the acquired image and how they're going to use it for medical decision making. So let's go through a few cases. So there's a typical case that we see here in our OR. We have a 44-year-old female. Just give me 1 second. Okay. We have a 44-year-old female with no past medical history who presented to the ER after she slipped and fell on the ice and fractured her leg. As you know, Houston just experienced their first snowstorm in 3 years, and we had about 2 to 3 inches of snow over here, which was historic. So she came in, and surgical plan was to get an ORI of her left tibial plateau. On her preoperative evaluation, there was an empty food tray next to her bed, and she insisted that she did not eat it. So would you postpone her surgery? Okay. Now, the next case is a 78-year-old male with hypertension, diabetes, and osteoarthritis presenting for a right total knee arthroplasty. Of course, she took semaglutide, which was about 7 days ago. He read up online that it would be beneficial to be on a clear liquid diet for about 24 hours prior to the surgery. And he states that his dose of GLP-1 receptor agonist was recently increased in the past 1 month. And he's really concerned about aspiration because he's read our JAMA news article and he thinks that he took all the right steps in preparation for his surgery today. And will you proceed with the surgery, and what would be your plan, right? So one of my smart residents was like, okay, fine, let's just do a gastric ultrasound on this patient. So we went through all the steps and I asked him, I'm like, so what is the indication for a gastric ultrasound? So in situations of an equivocal aspiration risk, gastric ultrasound enables clinicians to objectively determine gastric contents, facilitating an accurate and a reliable risk stratification to guide clinical management. So essentially you're answering two questions. Is it to determine the NPO status of a patient, or is it to determine the aspiration risk? So gastric ultrasound, again, is a risk stratification tool to minimize the risk of aspiration when the aspiration risk is uncertain. So it's used in patients with unclear fasting history, for any patients that have an altered mental status, or who, because of either drugs or just because of alcohol or just because of their general mental condition, whether they are not adherent to the guidelines. If it's an emergency, it can provide us some clue that the patient could be a full stomach and we may have to do something different. Language barriers, it's very useful in pediatrics and in conditions where there is delayed gastric emptying. For example, obviously the GLP-1 receptor agonists, renal and liver dysfunction, as well as critical illnesses can also cause delayed gastric emptying. So how can a gastric ultrasonography help? So healthy patients, and why are we even talking about it? So healthy patients may have residual gastric volumes up to 1.5 mils per kilo. And gastric antrum actually expands from a baseline empty state as the fluid enters into the stomach and the antrum, and it sort of expands in a linear fashion up to 300 mils. So let's talk about the gastric antrum. Remind me again, what exactly was the gastric antrum? We talk about gastric antrum a lot, but let's look at this slide over here. So as you can see, the anatomy of the stomach, you have the cardiac region, you have the fundus of the stomach, you have the body, and then you have the pylorus. As you can see, it's sort of like a J-shaped organ, and the structure that we're really concerned about is this pyloric antrum or the gastric antrum, right? So it is a funnel-shaped structure, and the pyloric antrum lies between the gastric body and the duodenum. So it is also important to know gastric ultrasonography when you have your surgeon telling you that your patient has post-pyloric feeding tube, but there is no recent abdominal x-ray and he still wants to proceed with surgery. So this is another way where you can actually determine where exactly your feeding tube is placed, whether it is beyond the sphincter in the first part of the duodenum, or whether it is just sitting in the pyloric antrum. Just another quick tool because we have to deal with it a lot over here. Okay, so let's look at the next slide. Okay, so gastric wall contains 5 layers. However, on gastric ultrasonography, the stomach wall can be visualized as 3 layers of altering echogenicity. The outermost layer is the serosa, which appears as a thin hyperechoic line, as you can see over here. The muscularis propria, which is immediately deep to the serosa, appears as a thick hyperechoic line and is easy to see on the ultrasound image. And the mucosa is the innermost layer of the stomach, which appears as a thin hyperechoic line. Occasionally, all the 5 layers of alternating echogenicity can be appreciated, but the 2 innermost layers are considered as an artifact due to the interface between the mucosal layer as well as the fluid in the gastric antrum. Okay, so other important structures that you can see here, you can see the gastric antrum, of course, which is marked as 6, the liver edge, which is 7, the rectus abdominis muscle, and the fat. So virtually any diagnostic ultrasound machine can be used to perform a gastric ultrasound. Ideally, the machine should be able to measure the cross-sectional area, or the CSA, and if available, the abdominal imaging settings should be selected, and an appropriate image depth should be chosen to allow visualization of the abdominal aorta, and we'll talk about this again. So a low frequency 2 to 5 megahertz curved array probe is suitable for most patients, and a higher frequency 5 to 13 megahertz linear probe may be suitable in small children, although we should ensure that we have adequate penetration so that we can visualize the abdominal aorta. All imaging is performed in the parasagittal plane. We hold the transducer so that the orientation marker points towards the patient's head or in the cephalad position. And when the patient is supine, most of our exams start supine. We expose the epigastrium, we'll position the cephalad trip of the probe immediately below the xiphoid process, and then we confirm the correct probe orientation by identifying the liver screen, by identifying the liver on the screen, and then on the left side of the screen, and then we locate the great vessels, we locate the inferior vena cava, and then we locate the abdominal aorta, and then we adjust the image depth so that we can see the posterior body of the vertebral bodies, and we try to look for the gastric antrum in that plane. So gastric antrum typically sits right near your liver edge as a little structure which looks like a nugget if it is empty. You also scan the abdomen, sweeping the probe from medial to lateral and keeping the probe still perpendicular to the skin, and you identify the stomach, you identify the liver, you identify the pancreas, you identify the superior mesenteric artery, the aorta, and the IVC. And then you examine the main structure, which is the gastric antrum, and then you look for anything that is present in the gastric antrum, whether it's solids, whether it's thick liquids, or whether it's clear fluids. Okay, so note that supine gastric exam is qualitative only and must be accompanied by examining the patient in the right lateral decubitus position. Okay, so let's look at this slide right here. This is sort of a reverse anatomy. You can see the liver, the SMA and the SMA, and then aorta, and then the gastric antrum. Okay, so position is the key when it comes to evaluating the gastric antrum. You cannot call a gastric antrum empty until you have turned the patient to the right lateral decubitus position. And I'll tell you why. So you can do a good exam in the supine position, and if your patient has solid contents in the supine position, then essentially your exam is over and your patient is not NPO, and you can proceed. You don't really have to turn the patient to the right side. Now, a full stomach or the presence of solids or thick liquids can be confirmed in the supine position, but again, it cannot be ruled out. Gastric volume assessment cannot be accurately performed while supine. After you complete the exam supine, you have to turn the patient in the right lateral decubitus position, and this position facilitates the flow of all the stomach contents to the gastric antrum, and hence you can assess the actual antral contents. Now, while the patient is again in the right lateral decubitus position, you use the same scanning method. You identify all the previously discussed anatomic structures, the liver, the pancreas, the SMA, and the aorta, and you may have to adjust the image depth because contents shift, and again, you evaluate the gastric antrum. Okay, so let's talk a little bit about what the stomach looks like when it's empty. So this is how an empty stomach or a grade 0 antrum will look like. Antrum appears small, flat, and pretty collapsed, as you can see. And it's about 2 to 3 centimeters in diameter. It is round or it's ovoid in cross-sectional area, and it has like a bullseye or like a target appearance. And it may or may not have a small amount of clear fluid that is present in it, which is essentially just baseline gastric secretions. So in the far field, also, you can appreciate your SMA and your aorta, and then you can look at your liver and then your rectus abdominis muscle. Okay. Now, clear fluids, as you can see, it's very obvious in this picture. It appears hypoechoic or essentially black, and it is homogeneous. Now, if the fluids was recently ingested, you would have some air bubbles, which is hyperechoic, mixed in with it, which sort of gives an appearance of like a starry sky appearance. And clear liquids in the stomach should be measured using the antral curved surface area in the right lateral decubitus position, and you should calculate the actual gastric volume. Once you calculate the actual gastric volume, you can determine whether it is an at-risk scan or a high-risk scan or a low-risk scan. Okay. Thick fluids appears hyperechoic and homogeneous, like milk and yogurt. gastric content containing a mixture of air and solids will have like a more heterogeneous or a frosted glass appearance. And any structures that are beyond the solid content, you really cannot visualize it because of the shadow. So you may see your SMA and your aorta partially in your far field, but essentially if your antrum is like full of solids, you just see like a dense shadow. And you see a pretty good air mucosal interface from the reflecting from the anterior wall. Okay, so how do we calculate what is an at-risk scan when your patient has just clear fluids in the antrum? Now, clear fluids, again, is like apple juice or like Sprite, all of that is clear juice. Okay, so this is the first method to calculate your CSA. So you take an image of the gastric antrum in the right lateral decubitus position, you freeze it, and then you use your free trace caliper on your ultrasound, and then you trace out from serosa to serosa, and you get a CSA, and then you plug it in this formula, and then you determine if the volume is less than 1.5 mils per kilo, which is clinically insignificant, or if it is more than 1.5 mils per kilo, which is a clinically significant result. You can either get the ml with that formula, or once you have the CSA in centimeter square from your ultrasound, you can plug it in with the patient's age, and it will determine the actual volume. And this is readily available in anesthesia and analgesia. The shaded area represents the low volume states, and which is usually considered within normal range. So for example, if your CSA is 7, and if your patient is 40 years old, that is essentially within normal limits for that particular patient. The second method to measure clear fluids is some of the portable ultrasounds can measure this pretty readily. And also the ultrasounds which have AI incorporated in them can use this pretty rapidly. So what this does is that you measure the anterior posterior as well as the craniocaudal diameters of the gastric antrum, and then you plug it in this formula, and then it gives you a CSA, and essentially you get a volume based on the previous chart. So a CSA of about 4 centimeters square equals an empty stomach. A CSA of about 10 centimeters square corresponds to a gastric volume between 100 and 240, whereas a CSA of greater than 10 equals to a volume of about 300. So quantitative assessment for clear fluids is unreliable in a patient who's had previous gastric surgery, gastric bands, any large hiatal hernias, or fundoplication. Even if your patient has had any of this, you can still put the ultrasound probe on the patient's abdomen, and you can do a quality scan. For example, if your patient has had a gastric band before, and if you still see food in the stomach, or you see solids in the stomach in the area next to the liver, and you are certain that that is not the small bowel, then definitely that patient is not NPO. But yes, if your patient has some clear fluids in the antrum, you cannot really make an assessment of the actual CSA or the volume in such patients. Okay, so now you've done your quality scan, and now you are trying to make a decision as to what exactly you should be doing. So you have come to the conclusion that your patient has an empty or a grade 0 antrum. So that patient is low risk. You're going to proceed with surgery. Or if you have clear fluids, so you're going to determine what the volume is. And then once you have determined the volume, you are going to ask yourself whether it is normal physiological volume states or whether it is greater than 1.5 mils per kilo, which is not physiological gastric secretions, and which suggests a high risk scan. And please note that I'm saying that it's a high-risk scan, and I'm not saying that the patient is definitely going to aspirate, because all a gastric ultrasound can suggest is whether your patient is at risk or not for aspiration. And if the patient has solid contents, then that is a very high-risk scan. Okay, so how are you going to decide as to what exactly you're going to do? Now, if your patient is negative for a full stomach, you're going to proceed with no aspiration precautions. If your patient is positive for a full stomach, you're going to individualize your patient management and whether the case is elective, time-sensitive, urgent, emergent, and what sort of aspiration precautions you may use. You may use an alternative for GA. You may prefer doing a block with minimal sedation or no sedation, or you may insert an NG tube pre-induction if the patient is really high risk. You would avoid an unprotected airway in the setting of deep sedation, and you may just do an RSI to actually secure the airway. So summary for gastric point of care ultrasound. So positioning is the key. You can never conclude that the gastric antrum is empty based solely on the supine position. You have to turn the patient on the right lateral decubitus position when you have a grade 0 antrum or a grade 1 antrum. Fluid assessment. If clear fluid is observed, you have to calculate the volume to distinguish between physiological secretions and secretions which are at risk for aspirations. And then if you have solid or thick fluids, then in the supine position, then that essentially ends your scan. You can scan the patient in the right lateral decubitus position, but if you see solids in the supine, your scan is at risk. And you always have to visualize the aorta or the superior mesenteric artery in the far field to confirm that you are actually looking at the gastric antrum. And quantitative methods are used for assessing clear fluids, unreliable in certain patients, but a quality exam can still provide you with some clinical information. So let's get back to our cases. So you remember that 44-year-old female with a questionable NPO time presenting for ORIF of tibial plateau, and a 78-year-old male with the GLP-1 RAUs undergoing the right TKA. So what would you do with this case? Would you delay surgery? Probably yes, correct? Now, so the first patient here was made NPO after midnight, and then we did the case the next day. And then the next patient, what we decided to do was we performed a spinal anesthetic. We did an adductor canal block pre-op, and then we essentially did very light sedation, just anxiolysis, and made sure that the patient was still talking to us, sedated but still talking to us, and able to maintain his airway reflexes. Okay, so we have spoken a lot about GLP-1, so I'm just going to briefly talk about the multi-society guidance for safe use of GLP-1 RA use in the perioperative period. And this is by our American Society of Anesthesiologists. I know there are several society guidelines, but this is the latest, which is released end of last year, and this is essentially what we are following. So it's like a multi-societal guidance, and I think I kind of like this guidance because it involves like a shared decision making between the patient, between the surgeon, and between the anesthesiologist. So you can interpret it in several ways, but it is pretty clear as to which patients are at an elevated risk for delayed gastric emptying. So patients that have had a recent escalation of dose, patients that have a pretty high dose of a GLP-1, patients who are on weekly doses versus daily doses, and any patients that have any GI symptoms on the actual day of the procedure, and whether those patients have any coexisting conditions affecting delayed gastric emptying, for example, Parkinson's or any bowel dysmotility. So as you can see in our patient that presented to us, he had a recent escalation of his dose, so I would put him in the high risk category. So the recommendations from the society is that you should have a shared decision making between the patient, between the proceduralist, between the anesthesiologist, between the prescribing care team. And they recommend that GLP-1 receptor agonists not be held prior to surgery. But if for some reason that we have determined that the patient does have significant gastroparesis because of that, then they recommend that we hold the GLP-1 for 7 days for once weekly dosing, and on the day off for the daily dosing. And every effort should be made to minimize the aspiration risk. We recommend a preoperative liquid diet for about 24 hours. And this is all just expert opinion. There is like no real data out there apart from the colonoscopy data, which is retrospective. And they also recommend the evaluation of the gastric contents using gastric ultrasound, or consider RSI versus delaying the case. So I hope my goal with this talk is to get you on speed with how exactly you can perform a gastric ultrasound and what is the actual benefit of a gastric ultrasound and how can you use it in your day-to-day practice, because you will see several patients who fall in any one of these categories, and you can use this tool to actually medically guide you to make sure that you're providing safe anesthesia. Thank you.
Thank you, Dr. Sen. I think you forgot to put up your own study slide.
Well, yes, it's old now.
No, nothing is old. The evidence is always good to know.
We are actually conducting another study to evaluate whether this 24-hour clears is actually protective or not. So I guess that should be coming up soon.
So that's the is diabetes a risk factor for impaired gastric mobility?
So
and
yes.
if they are on GLP-1 for diabetes, so what is your
most, if you speak to an endocrinologist, most of the actual diabetic gastroparesis is caused by the use of GLP-1s. So GLP-1 has been in the market for years. The only reason why we are talking about it so much in the past few years is because of its use in patients who don't have diabetes. They're using it for other uses. And we are seeing these patients who are aspirating, who we would not have considered to perform an RSI on otherwise. For example, if you have a diabetic patient, you automatically think diabetic gastroparesis, patient is at a high risk. Let me talk about all these X, Y, and Z symptoms. But if you have a healthy patient like you or me coming in with a GLP-1, I would probably not ask them these questions if they did not disclose that they are actually taking a GLP-1. So there was a study done by Dr. Perlas and with gastric ultrasonography, which was recently published, and she has some pretty good findings in this particular patient population. But most of the diabetic gastroparesis in diabetics is caused because of this particular drug. You're muted.
So much guidelines and guidance are changing nowadays. Initially, they say stop for 1 week, but if you see pharmacologically, you should stop 3 weeks for weekly medications to get the half-lives. So and now they say don't stop. So how do you deal in your daily clinical practice with the patients on GLP-1?
So that's a very good question. So there are ever-changing guidelines. So this is what we do now. So whenever we have a patient who is initially booked, if they are booked far in advance, one of the main screening tool when the surgeon actually books the patient is whether that patient is on a GLP-1, and then we also add an SGLT2 inhibitor to it because that's another side piece of the story. But if they're on a GLP-1, they automatically flag the patient, and that particular patient has to call the anesthesia clinic right away. So when the anesthesia clinic is called, we call the patient and we determine based on all of this, even before this guidance was released, whether the patient's at a high dose, whether the patient has an escalating dose, whether the patient has symptoms, was it a recent start, has it been a stable dose? And based on that, we give recommendations whether to hold the GLP-1 for a week and or to do a 24-hour clear liquid fast. So that has been our policy here.
Do you scan all your patients?
We do not scan all our patients. We scan our patients who have symptoms on the day of surgery. And again, recent escalation and dose changes. And if the patient just does not feel right, or if the anesthesiologist just wants to perform a scan. But if the patient has followed guidelines and there are no symptoms, then we just proceed with surgery.
Somebody is asking, role of gastric ultrasound in trauma and OB patients.
So in trauma, they are considered, and same with OB, they're just considered a full stomach. So you would just follow full stomach precautions and proceed. You can definitely do a gastric ultrasound to get some sort of a quality scan, but essentially they are just considered full stomach patients, and you do your usual.
Thank you. For all the listeners and the speakers, I just wanted to update you an important thing that will be coming up in gastric ultrasound. So we, the American Society of Regional Anesthesia, has recently completed the systematic review, and we are putting at the society guidelines on gastric ultrasound. So it will be coming up soon, because I can tell now officially because the paper has been accepted. So thanks to Dr. Stephen Haskins and the team that had led. So we have looked into all subgroups: diabetics, pregnancy, GERD, emergency, GLP-1. So huge paper coming out from American Society of Regional Anesthesia on behalf of gastric ultrasound guidelines. Look out for it. Probably in a couple of months, it will be coming out. And anyone interested in knowing more about the GLP-1, maybe I shouldn't be promoting myself. I did a nice podcast in Indian Journal of Anesthesia journal. Look at that podcast. We have covered most of the aspects of GLP-1. Is gastric ultrasound the answer? How to deal with them? Thank you. Dr. Sen, thank you so much being busy on call on the weekend, dedicating your time to us. Look
Thank you so
forward
much.
for your next study results.
Thank you.
Thank you. So thank you for joining us from India. So it's a night, I know I'm disturbing you, but a pleasure to have you here. She is one of the few cardiology anesthesiologists who has done an advanced training in cardiac anesthesia called DM in India. She has been a part of our ASRA POCUS courses. She comes all the way and teaches us here, shares her knowledge. Glad to have you here, Dr. Chigurupati. You can start your cardiac lecture now.
I'm unable to start my video.
We should be able to do now. Yeah, and make it a slideshow, Dr. Chigurupati.
Yes. So, good morning, everybody. It's a pleasure being a part of the second World Day of Regional Anesthesia. I especially thank Dr. Hari Kalagara for making me a part of this. So, for the cardiac focus today, we are going to deal about in three subheadings. I bring a lot of greetings from India. I have nothing to disclose. So, let us see why do we need this cardiac focus? What are we exactly looking and how do we do it? To answer the first question, why do we do this? Let us take a hypothetical situation where you have three patients coming to the ER around the same age of 65 to 70 years, all with a history of coronary artery disease, one of them having a history of gastroenteritis, but presenting with the similar complaints of breathlessness, low volume of pulse, low blood pressure. And the junior resident in the casualty has started fluids for all the three of them, but has seen that only one of them has improved. Showing improvement. He called the senior for help and he comes, spends 2 minutes with each patient and he changes the line of management. What he says is the first person can continue on fluids, second person needs inotropes with Lasix, and the third one surgical decompression. What is that he has seen is the first patient, the echo is this. There is a hyperdynamic heart where you can see the kissing papillary muscles, and this patient definitely will respond to fluids. In the second person, it is this picture he has seen. It is a very kinetic heart. It's a very weak heart. In this patient, starting fluids would only deteriorate the patient. The third one has pericardial effusion around, so he might need a decompression. So echo is one which helps us stratify the risk with the goal-oriented treatment. It is completely non-invasive, quick. What are we looking? If you people are into basic cardiac focus right now, I just want you to answer just 4 questions. Whether there is any effusion or tamponade, how is the left ventricle? We are not looking into the quantification, but we are looking into, is it good? Is it moderately bad? Or is it severely bad? The third one, what is the volume status? Will this patient respond with fluids or will the fluids be harmful in this patient? The fourth one, though it is not a part of the basic focus, is the right ventricle, because we are seeing a lot of cases of pulmonary embolism. You can see here as the right ventricle is usually less than the 2/3 the size of left ventricle. I don't know why my slides are going on their own. Yeah, it's less than 2/3 the size of the left ventricle. It is a crescent shaped with the interventricular septum convexity towards the right ventricle. But when you have a bad right ventricle or a dysfunctional right ventricle, what you have is it's a dilated RV, dilated LV, and you have an interventricular septum which is straight. So these are the 4 things we should be able to answer by the end of this session. But how do we do this? It is the phase array probe that we use. And just excuse me, the slides are just going on their own.
Maybe the timer is on. Take the timer off.
Okay, 1 second. Okay, where can I do that? Can you help me with it? Use timing I have taken out, but we start now. So what we use here is a phased array probe, because the piezoelectrical crystals inside the ultrasound probe they fire in a phasic manner to produce the image on the screen. So it has a very small footprint size so that it will be able to fit in between the intercostal spaces to visualize the heart which is present in the rib cage. So all the probes have the cardiac probes have an indicator on one side of it. This is to know which direction are we looking at. So this indicator correlates to this point on the screen. So next is, how do you move the probe, or what is the nomenclature that is used for the probe movement? It is either sliding to the right or the left, rotating clockwise or the anti-clockwise, and the tilting. When it comes to tilting, this is the tail of the probe. So you talk in the terms of tail up or tail down. So how do you hold the probe? The way you hold the probe is, for all the views other than the subcostal view, you hold the probe just like a pencil. And you rest the arm properly onto the body so that you have adequate control over the probe. And for the subcostal, you wrap your hand around the probe, and that is how you see the views. So having known about the probe, let us see what are the basic fate views. We are going to deal about 4 views today. The parasternal long axis view, where the indicator is towards the right shoulder. From here, you rotate the probe 90 degrees so that your indicator is towards the left shoulder, so that you get the parasternal short axis view. From here, move down to the apical view, looking from the apex of the heart with the indicator towards the left side, that is the apical view. And then just below the xiphisternum with the indicator towards the left, you're going to get the subxiphoid 4-chamber view. Now let us look at each of them separately. First is the parasternal long axis view. As the name indicates, if this is the long axis of our body, this is the long axis of the heart. So we are going to cut the heart. That means the ultrasound waves are going to cut the heart in this axis. So whatever are the structures to the right of this, that is what we are going to visualize on our echo machine. So these are the structures with the aorta, left atrium, mitral valve, and the LV with the anterior wall of the right ventricle that we're going to see. But why is the image like this is, as we know, this is the right side of the right shoulder, and we have already seen that whatever is there at the side of the indicator will be displayed on the right side of the screen. That is the reason our image turns, and this is the image we get onto our screens. So this is the aorta, this is the aortic valve, left ventricle, mitral valve, left atrium, interventricular septum, and the RVOT. So how do we get this on a patient is just in the second or third intercostal space with the probe towards the right shoulder. I'm just doing a little bit of window shopping around, and you can already see the view here. So this is how you get the views. So from here, there is one interesting structure you can see in the parasternal long axis view, that is the descending aorta. Why is it important? Because it helps us to differentiate between any pericardial or pleural effusion that is present. You can see in this example, this is the descending thoracic aorta, and you can see a mild collection between the descending thoracic aorta and the heart. This is a mild pericardial effusion that is present, and any collection that is present below the descending thoracic aorta is the pleural effusion. So let us see a few examples. So this is the DTA. You can see a large collection below, just between the DTA and the heart. This is a case of pericardial effusion, and this is the same example we have seen above. So this parasternal long axis view, we'll be doing the EPSS, that is the E-point septal separation, which I'll tell you in the subsequent slides. Next, coming to the parasternal short axis view. Once we have seen the long axis view, perpendicular to that is the short axis view. But the thing is, any body would have one long axis, but wherever this cuts will be the short axis. So you cannot say there is one short axis view. There can be multiple short axis views according to where you're cutting the heart. That is where the ultrasound beam is cutting the heart. So if it cuts at the level of the mitral leaflet, it is the mitral leaflet view, which you can see in this example. See, you're cutting the heart at the level of mitral leaflet. So you see a nice mitral leaflet view. Falling down is the mid-papillary view. And moving down a little further, you get the apical view. But you can do this by, and a little more, though it is not basic POCUS, here you also have an aortic short axis view where you have the aorta here You have the right ventricle pulmonary valve, you have the tricuspid valve. If you want to open up the pulmonary artery little more, you do a little tail down, that like what I have shown you, and you see the nice pulmonary valve and the pulmonary artery opening up with the branching scene. So that is how you get various levels of short axis according to where your ultrasound beam cuts. But for the basic POCUS, what we need is three views. That is the basal view at the level of the valve, at the level of mid-papillary muscles, and the apical view. So now let's see it practically on the patient. I'm just rotating the probe 90 degrees with the pointer towards the left shoulder, and you can already see that I get the mitral valve there. I move a little down, you get the mid-papillary view where you have the papillary muscles, and a little down, you get the apical view. To get this view, what are the movements I can do is, one is just swiping from up to down, or you can just stay at one position and move the tail a little down so that you can get these views. These are the two ways where you can cut the short axis at multiple levels. The next one is the apical view, where you're looking at the heart from the apex. For this, with the pointer towards the left side, I usually put the transducer at the apical area, and you can get the apical 4-chamber view, which you can see in the monitor. But if you want to have a better view, please ask the patient to turn to the left lateral position with his hand under the head. What this does to the patient is it opens up the rib spaces and the heart falls forward, and you have a better view. So this is the best view to do all the Doppler calculations, quantifying the M, because this is the view where you have the Doppler in line with the blood flow. So it is the best view to do the calculations, which we will be dealing subsequently. The next and the last one is the subcostal view. Here our primary aim is to get the IVC. So for this, you ask the patient to fold the legs, relax the abdomen, and just below the xiphisternum, dip the transducer down. You can see this nice subcostal view there. But since our goal is to get the IVC, tilt the transducer so that pointer is facing towards the head of the patient, and you will get the IVC into the view. So having seen the basic views, let us talk about some functional aspects of the heart. Our main interest is the systolic function. Consider the LV as a bag containing blood. Its only function to pump the blood into the body with minimum effort. So I can take this as an example. If you consider this as a water-filled towel, where I want to compress and get the maximum water out of it with minimum effort, this is not the movement I'm going to do. It's going to be the wringing movement, which is going to squeeze out the maximum volume. So that's what exactly happens with our heart, with a clockwise rotation at the base and an anti-clockwise rotation at volume each cardiac cycle. But the point is, our left ventricle does not fit into any of the geometrical shapes that are available. So we cannot use a single formula in order to calculate the cardiac output or the EF. So let us talk about one or two most simple methods in which you can calculate you can not calculate, but indirectly know the function of the left ventricle. So this is called as the EPSS, that is E-point septal suppression. If you closely observe the left ventricle, during the diastole, the mitral leaflet opens and almost reaches the interventricular septum. So in case when the mitral valve is normal structurally, just by eyeballing, you can see that this is almost going and hitting the left interventricular septum. So the minimum the space between this point and the interventricular septum, the better is the heart. In the second example, you can see that the valve is hardly opening. It's opening well, but it is hardly reaching the interventricular septum. So you can see it is a dilated LV and a very poor LV. So this is how you calculate it. Place an M mode across in the parasternal long axis view, cutting through the mitral leaflet, and you get a graph like this. And this is the E point, and this is the A point. The distance between this E point and the interventricular septum is going to be the E point septal separation. The lesser the value, the better is the LV. So usually it is less than 7. One more easy method to calculate the left ventricular function is MAPSE, which is mitral annular plane systolic exertion. Let us know what it is. If you closely observe the heart, during the contraction, during systole and diastole, the apex is almost fixed. It is not moving. it is always the base that moves towards the apex during every contraction. So in MAPC, what are we trying to read is this movement. What is this distance the mitral annulus is moving during each systole is what we are trying to calculate. So for this, the same thing, get a very good apical 4-chamber view. Concentrate, you have lateral MAPC or medial MAPC, whichever is possible. Just try to get the M mode and then get the wave. I'm showing this video just because if you move your cursor even before you freeze the wave, you're going to lose it. So till you freeze the wave, hold it in position, freeze it. Once you freeze it, you're free to remove your hand from the patient and you can do the calculations required. So I froze it. So I'm removing my hand from the patient and I'm doing the required calculations. Here is the example. Try to align it in line with the cursor and put the M mode. You can calculate the distance it has traveled between the systole and the diastole, and this distance is going to give you the MAPC. So because the least longitudinal excursion contributes to 60% of the stroke volume, it indirectly tells us the LV contraction. MAPC about more than 11 is normal, and it indicates a stroke volume of more than 55%. The lower it goes, the bad is the LV. So next one, similarly, you have TAPC for the right ventricular function. So the same, we'll follow the same technique what we have followed for the MAPC. Try to orient it along the lateral wall and then calculate the distance between the maximum exertion and the minimum point. Usually TAPC is almost double to MAPC. So 16 to 20T will be normal, and as we go down will be a dysfunctional RV. But the advantages is it is very simple. As you can see, the annular planes are very clearly visible because they are fibrous structures rather than the lateral walls. It is a uniplanar measurement, easily reproducible, no inter-observer variability. Then what are the disadvantages? The disadvantages with MAPC, TAPC or EPSS are all simple, and it is because of the M mode. To tell you the disadvantage, I want to tell you a little small story from one of the epics of Indian mythology, Mahabharata, where this is Arjuna, this is Drona. He tries to teach him how to be a best archer. And he says is, if you want to shoot the bird's eye, it is only the eye that you should be able to see, nothing else, not even the bird's face. Then only you become the best archer. So that is what M mode is. Whatever it wants to target, that is the only point it can see. So in that, it is very precise. But even next to that point, even if it is a completely akinetic part that is there, even next to it, it doesn't tell you. So you cannot tell the global function of the heart just using one-dimensional calculation. And it is affected by regional wall motion abnormalities, mitral valvular calcification, prosthetic valves, or valvular diseases. So we cannot use it as the sole technique to know the systolic function. So what else can we use is a simple global viewing, eyeballing of the heart at different levels in the short axis view is going to help us know the LV systolic function. I want you all to please observe the heart here. During every systole, you can see that the heart left ventricular muscle is getting thickened and it is moving towards the center. So these are the two movements that occur with every contraction. The wall thickens and moves towards the center. So if at all there is a decrease in the thickness or decrease in the thickening of the wall or decrease in the movement towards the center, then you call it as an abnormal heart. So you can see here, though it is not a perfect demonstration, you can see this part is slightly hypokinetic. This is completely akinetic, and is moving into the opposite direction every dyskinetic segment. So this is a clear picture showing you during every systole, it moving towards the center and thickening. So because we are talking about the basic cardiac focus, it is enough if we can tell whether it is a bad heart or a good heart rather than telling EF is 30%, 40% or 50%. So simple eyeballing, you can tell that this is a normal heart, this is a very hypokinetic heart, and this is a moderately dysfunctional heart. So, and one important slide we would all want to discuss about the aortic about the short axis view is this point, which will help all our clinicians, all our anesthesiologists and critical care specialists to determine what is the management required for the patient. Does he need volume? Does he need vasopressors? Or does he need inotropes? How is that? This is just an eyeballing technique. So I want you all to concentrate on the walls. This is the end diastolic volume and this is the end systolic volume, which are both normal. So this is a normal LV. So keep this in mind and we are going to compare the other hearts. So this is a heart where the end diastolic volume is low and end systolic volume is also low because you can see the kissing papillary muscles. So because the end diastolic volume is low and end systolic volume is low, we know that this is a hypovolemic heart and he or she requires fluids. If you observe this picture, you can see that the end diastolic volume is high, but the end systolic volume is very low. You can see the papillary muscles kissing each other during the systole. That means the end diastolic volume is normal or high with the end systole, which is very low. That means it is a low SVR. He will respond to vasopressors. This is a picture where you can see that the end diastolic volume is larger and even the end systolic volume is larger. That means this is a weak heart. So he will respond to inotropes. It is a poor LV. So in this way, the short axis view is going to help us determine what is the management required for the patient, even though all of them present only with low blood pressure and low pulse volumes. So these are some of the examples. This is a normal heart with a normal end diastolic and end systolic volume. If you concentrate on this, you can see that the end diastolic volume is low and end systolic volume is also low. It is a hypovolemic heart. And if you see here, the end diastolic volume is large and even the end systolic volume is large. That means it is a weak heart. It's a poor LV. So next, we are going to talk about the volume assessment, which we are going to do through our inferior vena cava view. So as we discussed from the subcostal view, we're going to turn the probe towards the patient head to get the IVC. And just after this point where the hepatic vein is draining into it, you put an M mode and you see two parameters. That is the diameter of the IVC and also the variation of the IVC with every respiration. So if the diameter is more than 2.1 centimeters with less than 50% collapsibility, you know that the patient has an volume overload and may not respond to fluids. And sometimes fluids may be dangerous in them. If the diameter of the IVC is less than 2.1 with more than 50% collapsibility, then you know he may need volume. But just taking the IVC parameter is not the best way to determine the volume status, but because it depends on multiple things, how you're cutting the IVC, the other parameters like any tricuspid valve regurgitation is present, pulmonary hypertension, and many other variations. So it is always important to take 2 to 3 parameters in view to determine whether he needs volume or not. Because if you see a collapsing IVC like here in this picture, and you see a hyperdynamic heart like this in the end diastolic volume in the short axis view, you are sure he will need fluid. So always correlate with 2 or 3 views to know the volume status. So you can see here, it is even by eyeballing without doing any measurements, I can roughly say that this is a collapsing IVC. He might respond to fluid, and you can see that here it's a dilated IVC with no collapsibility, and fluids may do more harm in this patient than good. So for a basic fate view, I think we have covered the basic what is necessary. The cardiac POCUS only needs repeated practice, and the most important challenge would be to get the views. So I suggest everybody to use the ultrasound machine just to acquire the views. Initially, you don't need to do any calculations. It is always the eyeballing that is important to know how is the LV, how is the RV, how is the volume status, is there any significant collection. If we are able to tell these points initially, it is very successful, and then we can go for the advanced POCUS, because it will give us a lot of information on how to deal with the patients, and we'll have less adrenaline rushes in the management. Thank you so much for this opportunity.
Thank you, Dr. Chigurupati. Amazing talk. So I think the most important slide that you mentioned in this one is differentiating the types of shock. So that's what I would insist for the people, and especially differentiating the hypovolemic versus the vasodilatory or septic shock becomes a really tricky one. So especially both are hyperdynamic hearts, how do you differentiate? So that animation and the slide was outstanding. Thank you for all your efforts. As we said, as you said, the basic cardiac ultrasound is all about getting the good views. If you don't get a good views, whatever calculations you do goes absolutely wrong. So the basic is always important is to get the views. So one of the participant is asking, how do you avoid the foreshortening in the apical four-chamber view?
Oh, yes. The best apical four-chamber view, I'll just show one of my slides, is when the interventricular septum is almost in the midline and you are able to see the apex of the heart. If it is aligned towards any one direction, then you're not getting the true apical four-chamber view. And most of the times, it is always a little tail down that you need to do in order to open the whole chambers of the heart. So wherever you're getting, and you can definitely see that the interventricular septum will not be in the midline, in the mid of the screen. I mean, if this is the triangular sector you have, your interventricular septum would be this straight when you get the true apical four-chamber view. And to correct it is little tail down at the apical position is all that is required.
Thank you. A couple of questions they were there. So cardiac ultrasound in pulmonary embolism as a cause of arrest. I will leave that question because we are having an exclusive talk on the cardiac arrest focus in the last talk. So we'll answer there. The next one is the diastolic dysfunction by echo. So unfortunately, this is a basic cardiac ultrasound lecture. We don't do diastology. That is not even for advanced. Diastolic by echo should be an expertise. So don't even go into those areas. Names looks fancy, but cardiac ultrasound, most important, the best and the most powerful tool in your perioperative medicine. You are guessing what is happening with an hypotensive patient. Just learn how to get the 4 or 5 basic fantastic views, how to optimize them, what to interpret, what to see in each view. That's the most important thing. Don't go for advanced and everything. So it all comes from slow learning, the best image optimization, and move forward. So people are telling that your presentation is really good. So the other thing is, what is the biggest barrier of cardiac ultrasound, especially in a country like India, when you want to incorporate into a clinical practice? Dr. Kirti, what do you think is the biggest barrier for you?
Your voice is breaking, Dr. Hari. Can you just repeat it?
So what do you think is the biggest barrier for your cardiac or practice or using cardiac ultrasound in countries like India? Is there any barriers you see?
Oh, I mean, off late, I think we don't have much barrier because ultrasounds are available in most of the ICU setups in our hospital, though we are not using them. So it is just that the machines are, I have a small portable GE machine, which I use it more frequently than the stethoscope I use, because it gives me enormous information if patient is deteriorating, because I being a cardiac anesthesiologist, patient is going bad, my only thing would be to go put the probe and see what is happening. That gives me a lot of confidence, because do I have to give him Lasix? Do I need to give him inotropes? Do I need to give him vasopressors? Is always a question in a deteriorating patient presenting with hypotension. So I cannot all the time wait for a cardiologist or echo specialist to come and give me an opinion on that. So, and the only barrier is our practice. It is only we ourselves are the barriers. I feel. I mean, I don't not in the negative way, but once we start practicing and once we get a hold of it, I think we will be benefited the most rather than any other specialties.
Yeah, those are the golden words. People say, I used to do the golden bow, I have done for years. Yes, we agree. But if you have a tool, which is that you can use at the bedside, negligible harmful effects, why not to use? Especially with the low cost portable devices, you just scan, you can see what is happening. And we are always looking for a goal-directed therapies, yes or no, binary answers, and to optimize and improve the patient care. So really great talk. PNDT Act in India is the biggest barrier. Yes, I agree with Dr. Kajal Jain. We all know that the issues, but things are improving. So at least if you have an hospital, you have an ultrasound, you can use it. So the mindset should be scan, scan, scan. Look for the cause. Narrow your differential diagnosis. Treat the patient. Then what? Then rescan again. rescan, reassess, then go forward. So this is the beauty of cardiac ultrasound. So one of the greatest tools, I think it is a game changer in your perioperative medicine. Simple example, elderly patients, they come for these hip fractures. We don't know what is their EF. We don't know how their aortic valve is. Just we put a probe, you know how the aortic valve, how the LV is doing, how the RV is. You can do big things, avoiding a disastrous spinal anesthesia in severe aortic stenosis, or you can titrate your anesthesia or increase your monitoring by just putting a simple arterial line, or you can tailor your postoperative care. And not even dumping fluids, as you are telling. We are always in a catch-50 situation. Hypotension means give fluids, then they don't have urine output, give diuretics. So we are all just throwing stones without having a concrete base or knowledge. So cardiac ultrasound is and will be, I'm telling you, will be the tool. Stethoscopes will be replaced very, very soon. Clinical examinations may not help you for all your patients. Thank you. We'll take a small break for 5 minutes and we'll come back and we'll join with our lung ultrasound lecture. Dr. Kirti, you can stop sharing your screen. Thank you. We'll come back in 10:35. Thank you all. Stay tuned. Welcome back. I could only give 5 minutes break. So we'll go back to our lung ultrasound lecture, which we missed it. So a lot of participants were asking about the recordings. All the recordings will be available. So you will have from ASRA. So whole webinar all will be recorded and you will have access to it later on. So please, you will have the recording version available. Thank you. Dr. Panziva, it's all yours now.
Perfect. Can you hear me?
Yes.
All right, perfect. So I'm going to start this, and I hope this time I apologize profusely for my computer giving in. I have a new computer now, and well, another computer, and it should work fine. So I'm resuming, or I'm starting over again, as it was just in the beginning of my talk. Again, I'm Oliver Panzer. I'm from Hospital of Special Surgery. And it is my pleasure to talk to you about lung ultrasound in the perioperative period. I have no disclosures. Basically, my goal is to talk about the basics of lung ultrasound, the most important applications and diagnoses that I think it is helpful in. It is a vast topic, and we could talk for way more than 25 minutes, but I hope to get over like the most important things. I decided to go with cases to highlight the ability of lung ultrasound to help us out in the clinical scenario. And so this is the first case. This is a 75-year-old gentleman who presented with a femoral artery occlusion. He is a smoker. He has COPD. He has some heart failure. His EF was 40% pre-op. He undergoes general 5 hours, loses about 1 liter of blood, and gets an arterial line and a central line in the IJ. But in the PACU, as he arrived extubated, but he's having worsening shortness of breath, he's tachypnic, low sats on 100% FiO2, and you get called to the bedside. And the question with the problem with these presentations, as we all know, is on physical exam alone, it is hard to make the distinction of what really is the underlying process, especially in patients with who are multimorbid like him. So many reasons why he would be desaturating. So before we start with lung ultrasound, this has been said in the chat already, I think you can use any probe. Probably the most common one is the phased array, the cardiac probe, because we do ultrasound rarely in isolation. We mostly perform it in the setting of cardiac ultrasound and fast. And so this phased array probe comes in handy as being able to do everything else. But sometimes I use the linear probe if I have a question about the more superficial surface analysis. So this is what we find in the patient, and you can see here I have representative images from the 4 anterior segments, and many times that's all I do. Maybe I add a lateral segment on each side of the chest, so a total of like 6 sectors that I screen, with the idea that if somebody is clinically symptomatic, the underlying process is not small, meaning I will probably or very likely pick it up by just doing a screening exam and not a full, intercostal space by intercostal space exam. So let's start with what we find on the right side. On the right side, we have several findings. I'm going to start with the A-lines. The A-lines are highlighted by the yellow arrows here on the side, and they basically are repetitive horizontal lines that are a so-called reverberation artifact. A reverberation artifact, and most of the lung findings that I'm going to describe to you are actually based on artifact analysis. These are reverberation artifacts, which means they're created by a reflection of the pleural line, and basically creating a mirror image of the pleural line at equidistant steps. And these steps, the width of these steps is dependent or determined by the distance between the top of the probe and the pleural line. And you can see that happens regularly. Sometimes you can see even more. 1 or 2 are normal. And what they mean is that if these A-lines appear, is that there's air underneath the pleura. The next sign that I wanna highlight is the so-called lung sliding. And again, here you can see I switch probes. I switch to a linear probe because it gives me a little more accurate depiction of the pleura, since I'm just looking at the superficial structure. You can see again, you identify, you scan in a sagittal plane, so head to toe plane, and you try to include a rib on each lateral corner of the image, here highlighted by the yellow arrows and the subsequent shadow underneath. So I know that's a bony structure. And then typically about 1 centimeter below, I see this bright horizontal line. That's the pleura. And you can see that there's movement. And this movement is created by the visceral and parietal pleura sliding against each other as the patient is breathing. So what does lung sliding mean? Lung sliding means that there is ventilation. So taken together, both the presence of A-line, that mean air, and a lung sliding at the pleural line is basically a normal lung pattern on lung ultrasound. So that's the case on the right side of the patient. So nothing really that strikes us as abnormal on that side. So let's move on to the left side of the patient's chest, the left upper corner. We do have a very similar finding on the first glance. As you can see, the repetitive horizontal lines that I pointed out earlier, these are A-lines. So it means we have presence of air, but the motion at the pleural line seems different. It seems more oscillatory. It seems faster than the breathing pattern. And so this is called a so-called lung pulse, and it's an abnormal finding. So the lung pulse, here another picture of a lung pulse, but this time again using a linear probe. And you can see the 2 rib surfaces again, and with the yellow arrow, you can see the pleural line, and you can see that this is clearly not a lung sliding motion. This is an oscillation rather, and it's synchronized to the heartbeat of the patient. And as such, the name lung pulse. And we see that this lung pulse comes to life when the lung sliding is not present. meaning the lung pulse is there all the time, but since it's such a small oscillatory movement, it typically gets blunted or like shadowed out by the ventilation pattern or the lung sliding that's over it. Once the lung sliding disappears, I can see the lung pulse. And so lung pulse means there is no ventilation. This has first been described by Lichtenstein when he looked at how a main stem intubation looks like on lung ultrasound. And he found this lung pulse on the side that was not ventilated, that was not intubated. And so this is a form, or lung pulse is basically a form of early atelectasis. Again, to differentiate and help you kind of visualize this, this is a lung pulse, and I put the EKG underneath to show you that this motion of the lung pulse is synchronized to the heartbeat, whereas the lung sliding that we showed earlier is synchronized to breathing, so typically slower, but also a much larger amplitude of motion. So that's what we find in the left upper corner. So there seems to be decreased ventilation in the left upper segment of the patient. And lastly, we do have another finding in the left lower corner of the patient. This is different entirely. So this time here, you can actually see not horizontal lines like the A lines, but vertical white lines, as you can see on this picture and as I highlighted with the yellow arrows. So typically important, we think these lines originate at the visceral pleura. That plays a role later when we talk about pneumothorax. They're hyperechoic, so they're bright white on ultrasound, and they're synced to pleural movement. If you look in this case here, as you can see, the pleural line is very thick, it's irregular, it's thickened, indicative of an infiltrative, of an inflammatory, of an infectious process, maybe. But many times when you see B lines like on this picture, they move with the visceral pleura. So they move with breathing, they move with a lung pulse if it's there, and they fade out A lines. So here in this picture, on the right side of the picture, you see like an indication of an A line, but you can see that this A line does not continue in the area where the B lines are. So these characterize the B lines, and the B lines stand for increased lung density, be it from a pulmonary edema from a cardiac standpoint, be it from an infiltrative process, or being a chronic condition like lung fibrosis. Interestingly, this Italian group with Copetti and colleagues in 2008 ventured out to see if I can use lung ultrasound alone to help me differentiate quickly if this increased lung density is related more to a cardiac pulmonary edema, meaning heart failure, or more related to the development of acute respiratory distress syndrome that does not necessarily come with heart failure. And what he did, he included 58 patients over 2 years in one ICU, 18 with ARDS, 40 with acute pulmonary edema. And he did a similar exam as I highlighted before, and 2 anterior, 2 lateral, and 2 posterior, 1 posterior segment that he scanned on every patient. And they looked at all kinds of signs, B lines, the pleural thickening that I highlighted earlier, lung pulse, spared areas, pleural effusion, consolidations, and absence of lung sliding. And what I want to highlight here, you can see in this graph, it shows it very nicely. You have the 2 groups. White bars represent the patients with ARDS, and the black bars represent the patients who were diagnosed with heart failure. And you can see while all of them have the AIS, the B-line pattern, there are distinct signs that only appear in one group. And you can see I highlighted them with these blue areas. Absent lung sliding, spared areas, consolidations are mostly present, almost always present in patients with ARDS, but you can see none of the heart failure patients had these signs. So this indicates that in certain scenarios, lung ultrasound alone can give you important hints as to where this increased lung density is coming from, as highlighted in this study. Now, one of the questions we had with this patient, because he got a central line on an internal jugular central line, are these symptoms related to pneumothorax? And this actually was one of the first diagnoses that lung ultrasound got very popular with. And I showed you a clip right here on the right side, taken with a linear probe in a patient that I knew had a pneumothorax. And you can see here, you can see the ribs at the lateral corners of the picture, and you can see a little bit underneath the rib again the pleural line, and you can see this time there's no noticeable motion along this line. There's nothing happening. Yes, there's motion within the soft tissue, within the muscular part, but at the pleural line itself, there's nothing happening. So that is the key feature of a pneumothorax, as the two pleural sheaths, the parietal and the visceral sheath, are separated from each other, and therefore I cannot see any lung sliding. And so absence of lung sliding and A-lines. A-lines should be present because in both scenarios, a normal lung filled with air or a pneumothorax, the chest cavity is filled with air. So for ultrasound, that's not going to make a big difference. So A-lines will be created in both scenarios. And actually, I think personally, it's an important sign to look for, because if you cannot find A-lines with absent lung sliding, you will see another diagnosis comes into mind. Other helpful findings that we mentioned before, B-lines, we said they originate from the visceral pleura. So B-lines should not be visible in a pneumothorax because the visceral pleura is detached from the parietal pleura, meaning there is a space of air between parietal and visceral pleura. So B-lines should not be able to be seen. Same for the lung pulse. Lung pulse requires both pleural sheaths to be in touch with each other. And lastly, the lung point, which is a specific finding for pneumothorax and helps with one problem that the absence of lung sliding, the hallmark of lung ultrasound for pneumothorax, is it has poor specificity because absence of lung sliding can be caused by other things like bullous emphysema, pleural adhesions, or overinflation. So the lung point is highlighted here. You can see on the left side of the screen where the P marker is, you do have something like lung sliding along the pleural line highlighted by the blue arrow. However, if you look on the opposite side, on the right side, there is no sliding along the pleural line. And again, I want to highlight in both scenarios, so the right side is likely the side of the pneumothorax. I don't have lung sliding here. I do have A-lines on both sides. And here, this is very likely a residual part of a collapsed lung that still is in touch with the chest wall. And therefore, I still see lung sliding. And the lung point is the point where I have the transition from the collapsed lung that's only partially collapsed because it still touches the chest wall to the area of the pneumothorax. And this highlights it here. I have a partially collapsed lung, and depending on where I put the ultrasound probe, I will see some preserved lung sliding. And if I go a little bit higher, I will see no lung sliding. Or if I'm lucky enough, like I showed you in the other picture, I see the transition zone exactly between the two areas. This has been shown nicely in a study by Liechtenstein, retrospective study in 200 ICU patients who did get CT chests, all of them, and they had 43 patients with, they call it occult pneumothoraces, they mean partial pneumothoraces, and 155 controls. And you can see here the sensitivity of absent lung sliding is 100%. Everybody in this group who had a confirmed pneumothorax on CT did have no lung sliding. However, it had a poor specificity. However, if you see the lung point as highlighted in the green area, the specificity rose to 100%, but the sensitivity dropped because only 43% had partial pneumothorax. 43 patients had partial pneumothoraces. So basically, in this first case, we did think that because there's only consolidation in one corner of the lung, and there is lung pulse only without lung sliding in the left upper corner. We thought maybe this is related to a mucus plug. We intubated the patient because of the worsening hypoxia. We did a bronchoscopy and removed large amounts of purulent secretions. The patient was developing a pneumonia, but did well post-operatively after 4 days. I want to move on to another case to highlight a different type of pathology. This is a 46-year-old woman. I admitted to the ICU. Actually, she was brought down hastily by the floor team with cirrhosis, admitted for spontaneous bacterial peritonitis after peritoneal drainage. She also had RV dysfunction and pulmonary hypertension. She came down hypotensive, on catecholamines, hypoxic, on 100% FiO2, and we performed a rapid sequence intubation, but we very quickly realized we could not ventilate her with very high peak airway pressures on a 100% FiO2 with very low saturations. Of course, after I just intubated, I said, like, wait, this was all like chaotic. Did we intubate the esophagus? Or is this severe ARDS? Or does she have a massive aspiration that was not witnessed? And is this the reason why? And before pulling the tube, we decided to perform a quick ultrasound as it was already at the bedside. And as I said earlier, most of the time I perform this with a cardiac ultrasound. You can see here, this is a hyperdynamic heart. There's no sign for overt heart failure here. But when we looked at the chest, and I did on the left side, you can see I did a sort of CT slice scan with the ultrasound. You can see there's nothing from the signs that I showed you earlier, but instead you see the lung as almost appearing as a solid organ. And indeed, I was initially questioning if I was in the abdomen and I looked at the spleen, but actually this was the lung, and you can see these black streaks inside the lung are fluid-filled bronchioli. You can see on the right side, this is it's a sagittal scan, so head to toe. You can see the entire lung is collapsed. There's not even a trace of air in there. And so that quickly, we decided to perform a bronch because we thought she probably massively aspirated. And you can see here that after the bronch, we can already see improvement in the sense that you can see the consolidation still here. So it looks like a solid organ, but you now can see air artifacts very shortly thereafter. That's the transition zone between aerated lung and still consolidated lung. So you can see we can assess progress and improvement. And I want to highlight that the signs that I've shown you are basically can be regarded as a continuum, as a assessment tool for worsening density, lung density, and therefore worsening lung ventilation, going from the normal lung of A lines and lung sliding to several distinguishable B lines, getting worse by confluent B lines, and ultimately resulting in consolidation, being the worst lung density possible with the worst ventilation. But as I've shown you with the last case, you can also use these signs and examination to look for progress, for improvement of lung density, and therefore better ventilation. The third case, I have 4 more minutes left. I want to highlight a 64-year-old woman with mild hypertension. She had a VATS procedure for wedge resection, and she is, we encounter her in the PACU where she's hypotensive, little tachycardic, stable SATs. She had a drop in hemoglobin, but she also had some intra-blood loss. She doesn't have any chest tubes, and so there are no signs of bleeding, but she does have cool extremities and reduced capillary refill. So we are worried about bleeding that we might not be seeing. And so we do a POCUS exam. And you can see, again, we do this as a whole exam. So we look at the lungs. So the heart looks hyperdynamic and maybe slightly empty, but not terrible. The IVC, however, suggests with her spontaneously breathing and a nearly completely collapsed IVC that probably her preload is low. And so we look at her lungs, but the anterior lungs don't look bad. There's actually lung sliding, there's A lines overall. So there's no pneumothorax that might cause like a decreased filling into the chest. And we do a lower ultrasound exam, lung ultrasound exam, where we look at the diaphragms, and you can see here on one corner we do see an area at the bottom of the diaphragm that looks kind of black. And black typically on ultrasound is fluid. And we're worried if this could be the early sign of an intrathoracic, of a hemothorax. And but sometimes this is difficult to diagnose. And I want to talk about an additional sign, the so-called spine sign, where we use the spine as a reference marker, as a reference anatomy to make the distinction. If you look at this ultrasound here, and you look at the area above the green arrow right here, it looks dark. It looks sometimes even like a collapsed area, like a lung collapse, like a lung consolidation. And it's very hard to distinguish that if it's true or just an artifact, like a mirror artifact. And we can use the spine for that. You can see here with the yellow arrows, you can see the vertebral bodies, the dark spots here along the spine. And the interesting part here is that the spine seems to stop once you go on the side of the intrathoracic space above the diaphragm. These structures are no longer seen, even though I know the spine continues. So this is an important sign to use. It's a so-called negative spine sign. And this is, I hope this explains a little bit. So if I have air above the diaphragm and I put my ultrasound probe at the liver, I will not see the spine because the air, as we know, does not allow ultrasound to travel fast enough to show any structures underneath a layer of air. So to me, to the ultrasound, it will see, like I showed you on the pictures, there's no spine to be seen. However, if there's fluid in the pleura, the spine will become visible for the length of the fluid collection. So that would be a positive spine sign and would confirm that there's actually truly fluid there. And if you can see here on this picture, different from the first one, I can see the spine highlighted with the yellow arrows, but I can see now the spine above the diaphragm. And so this black area with this hypoechoic substance in there, I now know, because I do see the spine in the thoracic area, that this indeed is pleural fluid. I'm almost done. These findings that I've showed you have been nicely summarized by Lichtenstein, again, in an algorithm that helps you differentiate the possible pathologic process depending on what you find on lung ultrasound. It is very helpful. There's also, I recommend reviewing these international evidence-based recommendations for point-of-care lung ultrasound, where they provide a nice summary of the findings and their sensitivities and downsides. So in conclusion, I hope I've been able to show you that lung ultrasound is a really valid and very helpful tool when it comes to the assessment of acutely hypoxic patients. It is reliable. It's been well validated by now. Pneumothorax can be ruled out easily. It is a little more difficult to rule it in with ultrasound. It's well suited, I think, to diagnose increased lung density, and in particular, to help you quickly differentiate if this is likely to be cardiogenic versus non-cardiogenic pulmonary edema or lung density. But it also helps, I hope, to show you if your measures that you are taking are leading to improved lung morphology. Thank you very much. This is the end of my presentation. This is my reference list.
Thank you, Dr. Panzer. Outstanding talk. When I designed this program, I thought I'm giving half an hour. So where are we? We'll have a lot of free time. I think I just am behind time now. That is the beauty of experts sharing their valuable knowledge and everything. Outstanding. So just I left one question before, probably we'll answer this one. What is the role of lung ultrasound for doing one lung ventilations or double lumen tubes?
I think I see a great, potential to kind of use that, because I've shown you the two signs that actually been looked at a similar situation for an accidental main stem intubation. But if you want to confirm that you're truly just ventilating one lung and that it's ventilated appropriately, you can use ultrasound to look at lung sliding on one side where you aim to still preserve the ventilation versus looking for lung pulse on the other side that should be, or the absence of lung sliding. These might seem like very, minimal differences, but once you start looking for it, you're going to see they're very well distinguishable, lung pulse from regular lung sliding.
Thank you. There is a question about the diaphragm. I intentionally didn't add the diaphragm in this topic because it becomes too big. I think I gave a big lecture on 30 minutes lecture on diaphragm in the last ASRA meeting. So hopefully we'll do it in the next World Day. So one of the greatest tools, especially being a regional anesthesiologist, you do the blocks, especially the intrascalene or supraclav, and they come to the post-op PACU, you're always concerned about, is it a diaphragmatic palsy or is it a pneumothorax or why is the patient hypoxic? So lung ultrasound along with the diaphragm is a great valuable tool, especially diaphragmatic thickening index and other stuff has been growing use for weaning of the patients, which is beyond the scope of his lecture today. So I'll leave that one. Another question is, what rib spaces are these scans being performed? This is a basic.
What rib spaces? So as I mentioned beforehand, you can, of course, you can do a very detailed lung ultrasound by looking at every single rib space that the patient has. But typically what we do is a screening ultrasound. And so what I meant is there's a nice publication, I didn't show this, but typically the agreement is that we divide the thorax into an upper area and a lower area, typically using the just above the nipple line as the difference between the upper and lower segment. And then we have an anterior segment and lateral segments, and even a posterior segment, which we barely use, but anterior and lateral segments. And so when I perform these ultrasounds, I'm typically somewhere in the middle of the anterior segment. Like up here, I'm in the middle, the anterior upper segment, and I'm in the middle of the anterior lower segment, and then maybe in the middle of the lateral lower segment. And these are the 3 points that I use. There's no, defined in my mind when I do these quickly at the bedside. There's no best intercostal space. It's just roughly you try to kind of be in the upper segment, in the lower segment of the anterior surface, and in the lower segment of the lateral to get a rough estimate of what is going on in the lung if there's any pathology. By the way, no pathology in somebody who's hypoxic is also very valuable. That should make you think about either a COPD exacerbation or a PE. I didn't mention that specifically.
Another great point is, Dr. Pranzari, as you always say, use lung ultrasound as an adjuvant when you're doing a cardiac ultrasound. If you don't have an answer or you have an answer or not, we always say incorporate lung ultrasound as a part of your cardiac ultrasound. Both go hand in hand. So always, especially to look just for simple B-lines or pleural effusion, we always highly recommend using both as twins. That's what I always say. Absolutely. And being a regional anesthesiologist, if you are doing an upper limb blocks, you have to know how to rule out your complications or side effects as well. So great tool, not even for the ICU guys. As ICU guys, I would say this is the best tool rather than cardiac. This is a game changer. So what they do with the lung ultrasound, avoiding repeated chest x-rays, radiations, every daily chest x-rays. I don't know why they do the chest x-rays every day. Maybe academic purposes, I don't know. Ultrasound is the answer.
I agree.
Thank you, Dr. Panzer. We'll move on to our next speaker now, Dr. Sana Khan from University of Texas from Houston. So glad to have her here. She's the director of point of care ultrasound there. She works in one of the most busiest trauma centers in the US. It's crazy. The place where she works is unbelievable trauma. Glad to have you here to share your experience, Dr. Khan.
Thank you, Hari. Thank you. I'm just going to share my slides. Okay. Can you guys see?
No.
No? Oh, wait, let's see.
No, I can't.
I did share. Hold on. Let's try again. Okay. No.
Coming up now.
Okay.
Yes. Go to the slideshow. Yes.
Yeah. Let me. Where is it?
Play.
Okay. How's that?
Excellent. Yeah.
Perfect.
Great. Okay, thank you for the introduction, Hari. As Hari said, I'm Sana Khan. I work here at University of Texas in Houston. It's a very, very busy trauma center. So we see all sorts of crazy things. It's honestly a privilege to work here. There's never a boring day. I'll just get right into it. I have nothing to disclose. So today, the main purpose of my talk will be to have an understanding of what is a FAST exam and to decide when to perform a FAST exam. So we have a 25-year-old healthy male, status post motor vehicle collision. Patient is being brought to the OR for an open right tib fib fracture. You go to evaluate your patient in the preoperative holding area, and the patient develops severe abdominal pain and becomes acutely hypotensive. On physical assessment, you notice the patient's abdomen is slightly distended. CBC, BMP, type and screen are all pending. What will you do next? So this is where the role of FAST comes in. So what is FAST? It's focused assessment with sonography for trauma. As we know, ultrasound is a reliable tool to evaluate patients presenting with acute or subacute thoracoabdominal trauma. FAST is a limited point of care ultrasound exam looking to identify any kind of free fluid in the intraperitoneal or pericardial cavities. Use of FAST exam in context of traumatic injuries, it really expedites time to definitive care, whether that's inserting a chest tube, doing a thoracotomy, or taking the patient for surgery. And as you can see the image down here, it's showing you the organs that I'll be talking about. So the heart, liver, spleen, kidneys, and the bladder. This is just to show you there's been many studies done to prove the value of FAST. So FAST in trauma patients, basically numerous studies have demonstrated that it has high sensitivity and specificity. Once you learn how to do a FAST exam, it's actually very easy to do. You can do it quickly, and which is why it's so effective in hypotensive trauma patients. And the sensitivity can approach almost 100% if you're an experienced provider that has good training in doing these ultrasounds. So the goal with your FAST exam is to decrease time to surgical intervention and basically, provide expedited care for these patients. So FAST exam has 4 views. They're labeled 1, 2, 3, 4. Position. I'm gonna go in detail about every view, but this is just an overview. So position 1 is your subcostal or subxiphoid view. Position 2 is going to be evaluating the right upper quadrant. Position 3 is looking at the left upper quadrant, and position 4 is looking at the pelvis. I wanted to quickly mention the difference between FAST versus EFAST in case you hear about what is EFAST. So we just had a wonderful lecture on lung ultrasound. So EFAST is basically evaluating a free fluid, for example, pleural effusion or pneumothorax. So you're evaluating the pleura. And you can do this in multiple areas, anterior and looking at the diaphragms. And I will show you when we're looking at right or left upper quadrants, you can quickly evaluate the diaphragm on both sides. So EFAST just includes pleural scanning. Okay, so what are the advantages of FAST and how can we apply it clinically? Like I said, once you learn how to do it, it's simple and effective. It can be repeated as needed instead of doing serial CTs, for example. Does not involve ionizing radiation. It's shown to have a high sensitivity and specificity, and which does increase proportionally to the amount of bleeding that the patient may be having. So what are some ideal clinical settings? Any kind of blunt or penetrating trauma in pregnancies, unexplained hypotension. As anesthesiologists, it's actually very useful, for example, in the perioperative time period, even if you have a patient in the PACU and they have unexplained hypotension, you're not really sure, what's going on, and they had some kind of abdominal surgery, it's probably a good idea to just quickly scan and do a FAST exam. Okay, so as far as equipment and setup, what do we need? So obviously you need an ultrasound machine. The most ideal probe, if you only have one available to you for fast exam, will be the curved array abdominal transducer. And the reason for this is that it gives you the most depth, since we're going to be looking at deeper organs. So the curved probe will be able to do that for you. Here, I'm just showing other pictures of, there's a linear probe and the phased array probe. Linear probe you could probably use in pediatric patients and still do a fast exam. The phased array probe is good to get views for your subcostal view. But like I said, if you only have one probe and you want to do quickly your examination, go with the curved probe. Okay, how do we optimize our patients for fast exam? So it's very simple. Think gravity and use it to your advantage. So if you're concerned about bleeding in the upper abdomen, if you place your patient in Trendelenburg position, it will increase sensitivity of detecting free fluid in the upper part of the abdomen. And same goes for if you place your patient in reverse Trendelenburg position, it's going to really emphasize if there is free fluid in the lower abdominal areas or obstructed cases. I just want to mention, be careful if you are assessing a trauma patient, if their C-spine hasn't been cleared, you don't want to do too much manipulation, but that's what this is showing. Okay, so we're going to go right into position 1, which I said was your subxiphoid view or subcostal view. Here you see the patient is lying supine, and we're going to be evaluating the space between the parietal and visceral pericardial layers, which is the pericardial cavity that surrounds the heart. This is the image that you're trying to obtain, and you see at the very top, you have your liver. That's what you're using, liver as the transducing window. Right below that, you have the right side of the heart, and just below that, you'll have the left side. And you see this shiny white hyperechoic line underneath the left side. That is your pericardial sac. So this is normal. I'm going to show you one that is not normal. So a tip for evaluating in this position, if you have the patient take a deep breath in, deep inspiration will actually push the diaphragm down, and it'll facilitate this view to bring the whole heart into view. And you see the white arrows are pointing to some hypoechoic, that's free fluid in the pericardial sac. So that's a positive exam. Okay, so position 2, now we're going to be evaluating the right upper quadrant. As you all know, what do we have in the right upper quadrant? You have the liver and you have the right kidney. So your goal is to basically assess the potential space between the liver and the right kidney. So ideally, there should be nothing, there should be no fluids there. As you can see, the picture on the bottom right, there, the white arrow is showing there's some free fluid between the kidney and the liver. Now, if you scan slightly cranial, you can actually also evaluate the diaphragm in this view. So it's kind of nice. You can go window shopping and do a quick exam to evaluate the diaphragm for any possible pleural effusion, to evaluate Morrison's pouch, which is your potential space between the liver and the right kidney. Okay, and now moving on to the left side. So the left upper quadrant, pretty much the same idea, except for instead of the liver, you have your spleen and the left kidney. So you're evaluating the potential space between the splenorenal recess. And again, the picture on the bottom right is showing with free fluid, just to get an idea of how that is supposed to look. I just want to mention, when you're scanning your patients, you know, in this view, they're lying supine and you're using your curved probe, you're pretty far back, like your hand is almost touching the bed. That's usually where I start scanning, and then I kind of window shop to get an optimal view. Okay, so position 4, this is our pelvic view. Here we're evaluating the bladder, and you can look, I would suggest it's good to look at both views. You have your longitudinal view and transverse view. So the longitudinal view shows the urinary bladder, and behind it you have your intestine. So you can see intestinal peristalsis. In the transverse view, you're looking at the bladder, and directly behind it is the rectum. And so you are looking for any free fluid behind the bladder walls. And so obviously, depending on if you have a male or female patient, the anatomy will be different. In males, you're going to have the retrovesicular pouch. Okay, so you'll have the bladder, and directly behind it will be the rectum. And so you're looking at the space between the bladder and the rectum in the transverse view. And for females, you're going to have the space between the bladder and the uterus. So that's the picture below on the right side is showing the uterus and the bladder. Okay. Let's see if I can play this. I just wanted to show, can you guys see the video? I wanted to show all these in actual like dynamics so you can see what it's supposed to look like with pathology. Okay, so right upper quadrant, we're looking at the liver and kidney. You're placing your transducer in the right upper quadrant. So here we are able to see that there is some free fluid between the liver and the kidney here. And depending on where you're scanning, you may see more fluid, and also depending on the patient's position, like I mentioned earlier. Okay, now we're gonna look at the left upper quadrant. So we're gonna be looking at the perisplenic space and evaluating for any free fluid. And here we see there is a little pocket of free fluid between the spleen and the kidney. Okay, moving on to our pelvic space. So they're going to be looking at it in the transducer is in the transverse plane. And look, here we have the bladder, and then directly behind it, there is some free fluid. And this is the sagittal plane. And this is a female, so you can see the uterus behind the bladder. And now they change the orientation and you can still see the free fluid. Okay, moving on to the pericardial space. So now we're looking at our sub-xiphoid view. And here we're looking through the liver at the very top, and then we see the heart is kind of floating. You see some fluid between the liver and the right side. Okay, that's all there. So basically, in summary, what I want you to take away from this talk is, what is the importance of the FAST exam and what are we looking for? So especially as anesthesiologists, I think it's very useful to have these skills. You can use it in the entire perioperative setting, whether you're evaluating your patient pre-op or post-op or even during their anesthetic care. And basically the goal is to do evaluation if there is any free fluid within the peritoneal or pericardial cavities. And so you want to be always asking yourself 3 clinical questions when you are doing a FAST exam. Is there free fluid in the pericardial cavity? Is there free fluid in the peritoneal cavity? And is there free fluid in the thoracic cavity? So the case that I presented at the beginning of this talk, the patient was actually found to have free fluid in the right upper quadrant, and he was taken for emergency XLAP instead of his tibia fracture. And that's all I have for you guys today. Thank you.
Thank you, Dr. Khan. So the other important thing I want to highlight to the participants, when you're doing an abdominal scan, being a perioperative physicians or anesthesiologist, is just scan the bladder. So I always say free fluid in the peritoneal, pericardial, pleural is good, but is there a free fluid and urine in the bladder also? Okay, yeah. So the important thing is we are always stuck with a situation of empty bladder or full bladder, or do you need to catheterize the patients or not? I just want to share a small example because I got a couple of minutes, which I thought I would do in the beginning, which I couldn't do. A classic example, recently, just like maybe within less than 2 weeks, we had a patient with a kidney transplant, a renal transplant. all completed, came back to the PACU. He was a little bit hypertensive. Usually these patients are diabetic, hypertensive, on renal failure, oligoanuric before as well, because they don't produce much of the urine. So he was hypertensive. They gave 20 milligrams of levodopa, came to the PACU, they gave another 10 milligrams. So 30 milligrams of levodopa was given because he was hypertensive. After that, there is a hierarchy system where you need to call your staff to give further doses. So they just called me, oh, we gave 30 of levodopa, the blood pressure is not coming down. Oh, you gave already 30? So, oh, blood pressure is too high, the numbers are high, they were treating it. That's what it means. Don't just treat the numbers. Look for the cause, what's happening to the patient. So I went to the bedside. I asked the patient, oh, I feel a little bit of discomfort in the abdomen and everything. So I just pulled my probe and I was looking and scanning. The surgeon came in and said, Hari, what are you doing? He was thinking, because usually the renal ultrasound people will come and do a renal ultrasound. He was thinking I was doing the renal ultrasound. I said, no, I'm just looking for the bladder. And unbelievable, the bladder was distended as almost 2 liters of urine was there.
Wow.
Okay. He had a catheter was blocked, nothing was coming out, completely full bladder. So if simple things, if you don't recognize or use your point of care ultrasound, we are treating in a different way, just the numbers. But sometimes, unfortunately, these patients are being treated as pain. Hypertensive, they think they are pain, they give opioids. Okay. So you are doing all things wrong. Instead of just putting a probe in the abdomen, but just for 10 seconds, hardly took 10 seconds. Then I flushed the urinary catheter, everything came out, nothing need to be given. So
Wow.
such a simple thing, putting at the bedside in the patients, especially the urinary bladder, empty or full residual urine calculations, huge difference. Do you agree, Dr. Khan?
Yeah, definitely. And I think just like you said, the great thing is, we have ultrasounds readily available and it's very quick and easy to do. So why not just, it's just better to do it. I've used it a lot actually in the post-operative PACU setting, and that's when it's very interesting to see how quickly your treatment changes according to your ultrasound examination.
Exactly. You don't even realize how simple and how useful, how game changer these things can be. That's what I'm telling. So always scan, especially in the fast. The important thing, couple of things are negative doesn't mean anything. You need to take the clinical contest, rescan, reassess, redo.
Yeah.
Because by the time you scan, there will not be anything. But when you rescan, it may be accumulating.
Right, exactly. That's the thing. That's the nice thing with this, that, instead of doing serial CTs, you can rescan, clinical picture changes. It's very dynamic situation. Even you're scanning, just the way you're scanning or the patient's positioning, it can change what you're going to see. So, yeah.
And be careful with some of the false positives and the false negatives. That's a high thing you need to keep in your mind when you're doing these scans also. There is a question asking, what probe do you use to scan the subcostal plane? Maybe it is a cardiac question or anything. I don't know. So you can use anything, phased array or curvilinear. Yeah. Usually for fast scans, we prefer the curvilinear because of the more depth and everything. But most of the people, I prefer a phased array because it's already there. You are scanning both this stuff. So it's an independent choice. You can do any probes as you wish and available for you.
Yeah, I agree. I usually, if I was only doing subcostal, I would probably also pick the cardiac phased array probe. But if I'm doing a full fast exam, it's just easier. You're already using your curved probe. It gives you more depth. And so, yeah, so either or.
Thank you, Dr. Khan, for sharing your valuable expertise.
Thank you.
We'll move on to our next lecture now. Dr. Bugrara, you can start your video. Yes. So we have Dr. Nibras Bugrara from Albury Medical Center. So he's one of the ICU clinical director and lead there. I can say only half what he does to the societies, to the point of care ultrasound. It takes me a whole lecture. Amazing works he has been done, especially the subcostal ultrasound, use of point of care ultrasound using the subcostal, which we call easy ALS. So he teaches everywhere, goes through the whole world. He develops his own courses, even in SCCM, Society for Critical Care Medicine. So he is one of the guys to teach how to do safely and effectively use point-of-care ultrasound in your cardiac arrest and ACLS. It's an honor and a pleasure to have you, Dr. Buglara, here. Thank you. Thank you.
Great. So thank you for the invitation. Thank you for organizing this really fascinating webinar and webcast. So today I'm going to be talking about something that's really near and dear to my heart. I'll be talking about incorporating point-of-care ultrasound into cardiac arrest. I have no disclosures, so I'll be covering the rationale of using point-of-care ultrasound in cardiac arrest. We'll talk about the algorithm, implementation, interpretation, and potential harms of using POCUS during cardiac arrest, and then we'll share our experience in training our residents in Albany Medical Center. So we'll start with a video. Why would we use point-of-care ultrasound in cardiac arrest?
Don't worry, Eric's you know. I'm going to do rhythm check. Pulse check.
Pulse check.
Yeah, there's a pulse.
I don't have a pulse.
That's gotta be looking right. That's a pulse, right?
I don't That's your pulse.
Fully different pulse, man. Here, let me.
No, I have a pulse here. Oh no, what are you talking about?
This is a pulse.
You know what? I'm writing you up for this.
I'm writing you up for this.
There's no pulse.
10 seconds.
We're not. We don't need to do compressions if there's a pulse, guys.
So it's funny. Well, does this sounds familiar? We know from medical school that PEA is basically zero pulse. And we know that cardiac output heart rate times stroke volume. In true PEA, the stroke volume is 0. But have you thought about if there's a small stroke volume that you cannot palpate? And this could be due to many causes. It could be due to tension pneumothorax, could be due to pericardial tamponade, massive myocardial infarction, massive PE, or hemorrhagic or hypovolemic shock, and then you cannot really find out with physical examination only, but if you apply the probe 2 centimeters below the xiphoid process and you utilize the lever to transmit the ultrasound waves, this way you can visualize the 4 chambers of the heart and the pericardium. So you can see if there's actual beat, if the heart is, if there's any organized cardiac motion or no, and you can differentiate between the possible etiologies. So examples. In this situation, we see that there is no organized cardiac muscle motion. The only motion is my hand, my probe over the patient's chest. In this situation, we call this a true pulseless electrical activity. Here, the left ventricle is trying to contract, trying to generate a stroke volume, but the stroke volume is very small to the point that you cannot really feel it. In this situation, this is probably a massive myocardial infarction causing PEA arrest. Here, you can see there is a lot of fluid around the heart causing RV collapse during diastole. In this situation, you can do chest compressions forever, and you're not going to get back your patient unless you are taking this pericardial fluid out. You're not going to be able to bring him back. Here in the right clinical scenario, you see how the RV is huge, bigger than the LV, causing septal shift. And in the right clinical scenario, you can blame this on massive pulmonary embolism. You need to give thrombolytics. And here you can see the ventricles are empty and there is no very small left ventricular end diastolic cavity. In this situation, you need to give volume and look for a source of bleeding if the patient is perioperative. Here you see that the patient has fine movement, fine dance. This is called fine ventricular fibrillation. In this situation, the screen shows flat line, but the contractility is there. Okay. So in you can see that in this case series, 8 out of 11 patients with cardiac activity on point-of-care ultrasound had ROSC, and 0 out of 24 patients or 23 patients without cardiac activity had ROSC. And this multi-center study showed that in more than half of patients who have cardiac motion have ROSC, and only 9 out of 378 patients with no cardiac motion had ROSC. So basically, this number is not zero, and for this reason, the echo shouldn't be the sole basis for decision making in ceasing resuscitation. In this multi-center study, more than half of patients who have PEA, cardiac arrest, have cardiac activity. And what was surprising is you see here that 10% of patients with asystole have cardiac activity. And the outcome, you can see that with this black bar, if there's cardiac motion and ultrasound, ROSC is much more prevalent. And 3.8% of these patients are discharged out of the hospital. And only 0.6% of patients who have no cardiac motion were discharged from the hospital. But we shouldn't be really discouraged by this number. We know these are out of hospital cardiac arrest. In hospital cardiac arrest, the around 37.5% will have ROSC and be discharged from the hospital, compared to 9.2% in the bottom decile hospitals. So the outcome is much better, but there's a lot of variation between centers. And that tells me that maybe there's something we can do to even further improve the outcome. One more thing about the in-hospital cardiac arrest. 72% of these patients who are discharged will have good cerebral performance category. That means they can live a life that is independent. So you're not really getting patients with poor neurological outcome if you save them. Most of these cardiac arrests happen in the intensive care unit, and many happen because of reversible etiologies like cardiac tamponade. So if you find out about it, you can manage it quickly. Tension pneumothorax, you can do needle decompression, for instance, PE, giving thrombolysis. So by treating the cause early, you might be able to save these patients. Even though now we know that point-of-care ultrasound is helpful, but we also know that our goals are to save the heart and the brain. So we need to make sure that there's good perfusion to the brain and heart, and also if there's any organized electrical rhythm, we need to bring it back quickly. That's why the ACLS algorithm starts by looking for shockable rhythms, because you need to get that rhythm, VTAC, VFib, shocked as early as possible, and start with giving oxygen and then doing chest compressions and give epinephrine. And only after 2 minutes of chest compressions, then you can basically look for causes with ultrasound. So we utilize the thoracic pump during chest compressions, which we basically do push 2 inches deep and then let for full recoil of the chest. So do not lean on the patient when you do chest compressions. If you do this 100 to 120 times per minute, then you'll generate 15% of cardiac output. That's enough to perfuse the heart and the brain. And with this perfusion pressure, you want to make sure that you don't elevate the venous pressure as well. So one of the things that you can avoid is doing overventilation. So you need to provide the ventilation smartly, only 10 breaths per minute, 1 second each time. Doing too much breathings or too many breaths can actually even reduce the perfusion pressure on the heart. If you do everything right, then you'll get enough perfusion pressure. And the moment you stop chest compressions, the perfusion pressure go to 0, and then it takes some time for the perfusion pressure to go up once you restart chest compressions. So all this time lost here with no perfusion can impact the outcome. For this reason, the American Heart Association guidelines said you can start CPR early as much as possible, and also do not interrupt it for more than 10 seconds. In 2015, it's the same guidelines. In 2010, all these guidelines throughout the year very much focused on not interrupting chest compressions for more than 10 seconds. So I told my residents, you have only 10 seconds to obtain your views. And you can see that there are too many kinds of residents. You can see here, this is the very enthusiastic resident. This is very suspicious. This is a dreamer. For the suspicious type, I told them, you know, obtaining subcostal view is not that hard. Even children can do it. The suspicious resident told me that in 2017, there is a problem. 2 studies were performed that when the physician performed point-of-care ultrasound, the outcome where the gap between the pauses for chest compressions were prolonged by more than 8 seconds. So basically, when you use ultrasound, there's association with prolonging the pauses, which could harm the patient. So I told them in these 2 studies, there was no training and no employment of a specific protocol was done. And by training, I meant something like coordinating efforts or something similar to this. Where the team works in tandem to provide the best care. And so I'm going to share with you this protocol. We have too many protocols, but this is the easy ALS protocol, which we published in 2019. It's based on the field exam. It starts with recognizing crisis, call for help, begin CPR, secure the airway, and only after 2 minutes of CPR during the pulse check pause, you can apply the ultrasound. And then at the end of 10 seconds, you will resume chest compressions again. During that time, you check for rhythm on the monitor, you check for a pulse, and the sonographer can look for whether there is cardiac motion on the heart, or if there is no cardiac motion. If there is cardiac motion, then a diagnosis with pseudo PEA could be diagnosed, and then you start looking for the etiology. If you cannot obtain a view within 10 seconds, then you resume chest compressions, and the next cycle you can try again. So this is the algorithm. It seems complicated, but it's really simple. It starts by perform high quality chest compressions for at least 2 minutes, and then say we're going to do an ultrasound, and then prepare the patients by removing barriers. Place the ultrasound probe on the patient, announce that there is a pulse check will be done in 10 seconds, count down 10 seconds, and then perform the ultrasound while the cold leader counting down. You record the images, and only after resuming chest compressions, you will review the recorded images and then give interpretation to the code leader. This is an example. Hey, can you hear me? Can you hear me? There is no carotid pulse. Sinus tach on the monitor. Hey, Sean, can you start chest compression? Hey, Mike, can you call for help? Get AED and the code card? Sure. Lynn, can you help with the airway? It looks like we're in the PEA algorithm. What cycle is this?
Starts here, starting 5.
In 10 seconds, we will check for pulse, rhythm, and we'll get a field exam. Eric, can you break the echo?
Come in with the ultrasound.
1 milligram of epi, please.
Yeah.
All right, 10,
Epi's in.
9, 8, 7, 6, 5, 4, 3, 2, 1.
Okay, acquiring images.
8, 7, 6, 5, 4, 3, 2. Resume chest compressions.
No pulse. Okay, there's no pericardial fusion. RV's moving well. He looks grossly underfilled. I think he's hypovolemic.
Hey, Mike, can you grab a bag of saline and 1 milligram of epi? Sure. This is how every single code run in your hospital. The only thing is missing is some soft music in the background. So the Germans did realize using they were the first who implemented this. So Dr. Berkowitz designed a one-day course to train physicians on obtaining point-of-care ultrasound in 2007, and showed that after 1 day of training, most of the physicians were able to obtain quick view of the subcostal in less than 10 seconds. So this is the first hands-on session on the left. Many of the physicians weren't able to obtain the point-of-care ultrasound of the heart in less than 10 seconds. But at the second hands-on session during that day, the majority were able to get a view. If you look to the right here, the instructors were able to get views, the majority of them, in less than 5 seconds. Also, the ability for these physicians to interpret images of the 5-second video clip was improved much dramatically after 1 day training. Because remember, the pathology is very evident. If you have, for instance, a myocardial infarction that's causing PEA arrest, then the ventricle is going to be really down. So the functions, the pathology is going to be very, very pronounced, to the point that with 1 day training, you can pick on it.
Oh, look! There's a heart! Good. And they can pump ANSA. That's all we need.
So yeah, this is orthopedic surgeon happy that the heart is pumping antibiotic to the bones. What about the societies? What do the society say about using ultrasound in cardiac arrest? So the American Heart, the AHA guidelines said that if there is a physician who knows how to use ultrasound and can use it safely, then they can go ahead and use it. So they weren't very, very supportive, but they weren't objective at the same time. In 2020, the only update they added is they suggested against the use of point-of-care ultrasound for prognostication during cardiac arrest. Because we saw in the previous study that there's a few percentage of patients, 9 out of 278, had ROSC despite having standstill, so cardiac standstill. So do not use the cardiac motion alone to decide to stop chest compressions on a patient if they have no cardiac motion. You have to use the entire clinical judgment. The European Resuscitation Council were more progressive, and they suggested that point-of-care ultrasound, that there's no doubt it can detect reversible causes of cardiac arrest. Okay, and but they recommended using specific protocols. These are all protocols that utilized ultrasound during cardiac arrest. You can see FATE here is included. And at the bottom, this is the easy ALS that I'm talking about today. What about the Society of Critical Care Medicine? They gave point-of-care ultrasound application after ROSC, grade 1B, and the reason is to look for regional wall motion abnormality, because if you find one, then the patient needs emergency cath right away. So, and they gave this grade 2C to utilize point-of-care ultrasound during pulseless electrical activity. They recommended that all levels of trainees can do point-of-care ultrasound during cardiac arrest, not only the experts. So, and the levels of trainees starts from level 3, which are the cardiologists. Level 2 are the intensivists who pass their critical care echo boards and basically received critical care training on ultrasound. They use it routinely. At the bottom here, you can see that this is the trainees who received, for instance, 1 day course and received and performed at least 30 exams. So these are the basic level of trainees. Those can perform point-of-care ultrasound during cardiac arrest. The Society of Critical Care Medicine defined minimal training by 20 hours of lectures combined with 30 performed exams and 50 interpreted exams of focused cardiac ultrasound. Now I'm going to share with you our experience in Albany Medical Center on applying ultrasound in cardiac arrest training. So in 2014, I completed my training in critical care and critical care echocardiography. And then 2015, joined Albany Medical Center. And during that year, I gave a talk or grand round to everyone explaining what is point-of-care ultrasound and why we should adopt it. I was really trying to convince our chair to give me $12,000 to buy a phased array probe that I can use with our already available machine, ultrasound machine. So at the end of the talk, I think it went well because the chair gave me the money and we bought our first cardiac probe. So now we trained all our residents, started training by doing a pre-test where I tested everybody's information and background on point-of-care ultrasound. This guy was taking it seriously and he probably was cheating. This is a heart in his hand. But followed by, I trained everyone with 1 day point-of-care ultrasound course, where in the first 2 hours, we gave lectures. We had the residents review some online videos, around 2 hours videos, followed by hands-on training. And after all, the 1 day course, we felt, is it enough? Clearly, it didn't meet the Society of Critical Care Medicine baseline criteria, which is 20 hours of lectures and 30 performed exams. So when I was giving a talk at the one of the SCCM Society of Critical Care Medicine courses, which we were conducting twice a year, and we were recording all the videos, lectures, similar to recording the seminar today, I thought, what if we use the recorded lectures to train our residents instead of reinventing the wheel and giving lectures? Why don't I utilize these videos that are already available? So I asked the chair of the SCCM Critical Care Ultrasound committee about using the videos. I didn't notice that he has a knife in his hand, but thanks God, it went okay, and he gave me permission to use the videos. So we developed a 5-day course for our residents. 4-day in the mornings, we do review the videos of the SCCM lectures, supervised. This is happening during the PACU rotation of the resident. And then the afternoon, we scan 5 patients in the ICU. So this is the curriculum. You can see that these are the lectures we provided, basically physics, ultrasound, assessment of ventricular function, volume assessment, FAST, similar to the lectures you reviewed today. So in the morning, we view the lectures together, where basically I was sitting in the class with the residents and giving feedback, pause, and do discussions. So each half an hour lecture, we viewed over 1 hour. And then the afternoon, we basically do scans in the ICU. So we have the trainees scan at least 5 patients. As you see here, between and during lectures, we do a lot of discussions. So here, one of the residents is showing us how to calculate stroke volume, revising how to do it. And so I understand that they're not just sleeping, watching lectures, but they're actually participating. After this 4-day training, we did a post-test, and before the 5th-day training. And then after 6 months, we did another test. We noticed that residents who received the 4-day training passed their SCCM exam, which is validated test, 30 multiple choice questions. You see here in years 2016 to 2019, the majority passed. and scored more than 70%, which is the passing score, which was what was really surprising is 6 months later, we showed that the residents retained their knowledge. So we took the experience to Mayo Clinic, where in Jacksonville, where Harry is, and his residents did the similar results, and then University of Vermont. So we were showing that we can implement this in standardized course in multiple institutions, and we get the results. Here, we implemented this in 7 institutions for anesthesia critical care fellows. You see that the pre-test, the pre-course passing rate was only 29%. After the 4-day course, 88.6%, and then the passing rate was 97% at the end of the academic year for the anesthesia critical care fellowship year. Before implementing this standardized course, the passing rate for these fellows was around like 60% only. Part of the training was to review all the images that are obtained by the resident. So we look at the image quality. You can see here they obtained, the image quality was around 80% of the time good. The majority of time, around 97%, the residents were able to obtain at least one cardiac view, but it took around like 18 minutes. Then we implemented the simulation day. Simulation where we had high fidelity team simulation. We had the residents apply point of care ultrasound during cardiac arrest. And we look for specific mistakes they would make. For instance, the ultrasound could be a distractor here. So we make sure that the team is not distracted by it. We make sure that they do good exposure to the area that they scan. And here's an example of one of the simulations.
2, 1, time for pulse check.
Pulse check, looking at our rhythm. Looks like a non-shockable rhythm. Do we have a pulse?
How much time?
No pulse. Countdown time, please.
5, 4, 3, 2, 1.
Okay, can you
Resuming chest
get a milligram of epinephrine, Darcy?
Yes.
Let's see your hand down. Thank you.
All right, guys, there's no sign of any pericardial effusion, so it's not cardiac tamponade. The right ventricle is small in size and hyperdynamic, so no increased risk for pulmonary embolus. It looks like we're underfilled. We need some volume, guys.
Okay.
1 milligram.
So what do we think? Do we think they did a good job? To be honest, they did not do a good job because the pause here was 17.5 seconds. The goal is to do countdown and do chest pulse for chest compressions to obtain ultrasound in less than 10 seconds. And this study showed that if you do 5 simulation sessions with the residents or fellows, you can see that there's improvement in the chest compression pauses as you increase the resuscitation simulation. Finally, in 2019, we got IRB approval to utilize ultrasound during cardiac arrest by the residents without the attending supervision. So all these residents who pass all this training, the 20 performed exam, the 30 performed exams, the 20 hours of training, were able to do ultrasound during cardiac arrest without the attending presence. And the goal was to find these phenotypes, one of these. For instance, first they need to realize, to focus and see if there's cardiac motion or no. And if there's cardiac motion, they look for phenotypes like pericardial tamponades, right ventricular failure, and indication for instance, PE. So all these phenotypes. And I'm going to share with you some examples of scans done by the resident. So you can see here that this patient has some cardiac motion. So this was a pseudo PEA. The repeated exam showed that the patient had ROSC after the second session. And here you can see the base is contracting very well. The body and apex is not. So this is an example of Takotsubo. But we called the cardiologist to see the patient to evaluate for cath because this is a regional wall motion abnormality. In this case, we had a cardiac arrest in the operating room. You can see there's a clot in the right atrium. So this is an example of massive pulmonary embolism. The patient got thrombolytics. Now, during chest compressions, you can obtain views from the extracardiac locations. For instance, you can look at the inferior vena cava to see if it's full or flat. You can look for pleural effusion. You can look for the airway, whether it's in the esophagus or trachea. You can look for pneumothorax. So here's an example during chest compressions. This patient has plethoric IVC. And then when we looked at the cavity, the pleural space here, we found this very severe pleural effusion. And in this situation, the effusion was causing tamponade. So we didn't have time to get a chest tube. We didn't have chest tube. We made a puncture. We cleared that massive effusion, and we were able to obtain ROSC. Now, of course, I don't recommend you doing this. Try to get a chest tube in these situations rather than just making a puncture like that. For the the IVC, when the IVC is flat, initially it can indicate hypovolemic or hemorrhagic shock. When it's plethoric, it could be due to any other reason. So there is a use for the IVC, especially early. We published these findings. So our residents reported 22 patients, where in all of them they were able to get some sort of imaging during cardiac arrest. Now remember, these are self-reported, and you can see that these are the etiologies of cardiac arrest. And we had, out of these patients, we have 9 out of 12 had ROSC, and the 3 who didn't have ROSC, 2 of them had cardiac standstill. So in conclusion, this shows that it's possible that you can apply ultrasound in cardiac arrest, and you can basically train residents in 4-day training to obtain that. It's really important that we train the residents in a simulation setting. So this is a course that we provide at the site of critical care medicine that is a full day training where we just train residents and trainees on utilizing point of care ultrasound during cardiac arrest with simulation. Finally, I'm going to share with you our experience in Libya. So 2 years ago, we ran the course in Libya, where we did a 3-day training session for the Libyan physicians. And this is an example of the first simulation session.
We can improve. Okay, check the pulse. Okay, patient stop in the compression. Check the return of circulation. Okay, we have pulse. Pulse. Okay.
So here you can see they're trying to scan through the dressing. They didn't even remove the dressing. They didn't put a board underneath the patient. The interruption of chest compressions was horrendous. So the performance was very low in the first session, to the point that even the mannequin didn't make it. So the mannequin really poor mannequin. We gave some feedback about the performance of these residents and physicians, and then we revised how to do chest compressions effectively, time and depth, on music. And then this is the last scenario of the day. I want to show you how much improvement.
Okay.
So here now they're applying boards behind the patient.
Improve compression,
chest compressions better.
Rhythm and depth. If you are tired, you can switch. 10 seconds till ultrasound. 3,
2, ultrasound
Now
please.
they're applying ultrasound in less than 10 seconds.
9.
There's a large thrombus
There's clots in this.
Advanced thrombolytics please. Okay.
You saw an example here of closed loop communication, and the results were really impressive. So, and at the end, the mannequin made it. You can see here, happy, just need to be extubated. And I think just about the mark, hitting the mark of 30 minutes. So in summary, you can use ultrasound during cardiac arrest, but if you use it safely by not prolonging the chest compressions for more than 10 seconds. Thank you. Open for questions now.
Thank you, Dr. Bulgara. Always fascinating talks. And the amount, the best part of Dr. Bulgara is the way he shares the knowledge to going to different countries, different places. I think he did in Thailand, he did in Libya, everywhere he goes, trains, and he gets the feedback, continues his training. Amazing. I got just a small question asking, what are your thoughts on integrating or incorporating transcranial Doppler during cardiac arrest to check the adequacy of compressions or to see the progression of the cardiac arrest?
So my experience with transcranial Doppler, that during chest compressions, there will be a lot of motion, a lot of artifacts. I'm not sure if this is actually feasible at this point, because during chest compressions, you want to focus on looking at the heart. During pauses of 10 seconds. And then during chest compressions, by applying ultrasound here, there's a lot of artifacts, the patient is shaking. And then what are we looking for? I've never done that, and I'm not sure there's any evidence showing that this could be helpful. Now, in the future, if you have a sticker that you can put here and get you continuous ultrasound waves, maybe, but at this point, there's I haven't heard any use for it during chest compressions or cardiac arrest. Now, post-arrest, to look at the brain perfusion, that's a different story. And it could be used to detect, for instance, intracranial hypertension and other things. So there might be a use after, post cardiac arrest or post ROSC.
I might allow a couple of participants to speak because there are a couple of people who are keen to ask. Dr. Banu, what do you? I let you speak. Do you think? Can you ask your question?
Yes, sir. Hi, good morning, everyone. Am I audible, sir?
Yes.
Okay. Firstly, before I ask my question, I would like to thank Dr. Hari Kalagara for stimulating us to use POCUS and ultrasound more and more than what we previously used to do. So in this journey, we were actually more interested and drawn to doing gastric POCUS, even for non-indicated cases, just to see how far this fasting guidelines actually match with clinical findings. So we did 120 cases, and interestingly, we found at least 10% of patients, even with more than 8 hours of fasting, have grade 2 stomach. So my question to Dr. Sen is to how we address this clinical dilemma when there is no linear relationship between hours of fasting to finding empty stomach.
Thanks, Dr. Banu. I think Dr. Sen is not here, so you put me in the hot spot now.
Okay, sir.
Which is good, which I like it. So it's a great question. That's the reason, if you look at the literature of the fasting guidelines across Europe, Canada, North America, or even in Asia, that we take 8 hours as the fasting because it's variable. And again, it depends upon how much fat you take and how much type of food you ingest. So again, it depends upon what pre-existing conditions you have. So patients may have chronic renal failure, diabetes, other medical illness that might be impacting the normal fasting. Simple thing, when your patient has a pain or being on opioids, 6 hours, 8 hours is not a number at all. It doesn't matter. So all these things which we talk about is told about healthy patients being fasted. But when you see the patients coming to the hospital or for surgeries, they're not healthy. So we are extrapolating the data from our healthy patients. So there is no linear relationship. It can be either ways, especially with the type 1 diabetics. It can be 12 hours, 14 hours with gastroparesis to empty the stomach. So the only tool I say is, if you are not worried, use a gastric ultrasound. The number is really for healthy patients, which we don't see that often in our clinical practice.
Okay. Thank you, sir.
Thank you. Dr. Nima is asking for Dr. Khan, if you don't have an hospital setup where you have a trauma, how do you recommend training your residents? So I'll take the hotspot again. So Dr. Nima, yeah, I know everybody doesn't have a trauma. So you need to utilize the only thing you miss in the trauma not having is a fast scans. Remaining else you can do in routine ICU, pre-op, post-op, everywhere. For these cases, you just figure out your ICU patients or post-op patients that come up from major abdominal surgery, and you train them with SimLab and train them with the normal patients and show them the clips of pathology. The one thing I want to highlight to all the participants here is, as the POCUS is growing and becoming more in clinical practice, people ask questions about billing, credentialing, privileging, and everything. Being in North America, it's a big thing how you bill, how you get credential. The only thing I would recommend to people is do courses, get some certifications or certificates, especially our American Society of Anesthesiology has started a beautiful POCUS certificate, diagnostic POCUS certificate in all these areas. So especially the cardiac, lung, fast, and gastric. And they started unique gastric on its own because of the GLP, all these staff are scanning nowadays. So use the ASA resources to get a certificate that can be added, a valuable tool. Achieve the minimum number. Don't jump in with 1 or 2 scans and rush to do the diagnosis or do the things. It's a great tool in the right hands with the right training and the right process. So a couple of questions, Dr. Nebras, for you again. Is there any role for ultrasound images during CPR and legal values?
Sorry, say that again.
Any litigations with ultrasound images during CPR or any legal implications?
No. So the only legal implications are the only time physicians sued that I heard about in the US is emergency physicians who did not use ultrasound for patient in shock, and the ultrasound was available in the emergency room. So far, I'm not aware of any litigations except for having the technology and not using it correctly.
Yes, especially even recently, the Canadian Society has published a nice article on POCUS litigations. The same answer, not using POCUS, you are more litigated than using it. So what always Dr. Bruguera says is, save the clips, save the clips. You're not interrupting any process. With the subcostal between, save, and you're interpreting the images with the saved clips. Don't stop CPR. That is a take-home message when you're doing this easy ALS subcostal, even with subcostal. Dr. Bruguera, do you recommend using portable ultrasound probes around moving the hospitals, doing code blues?
Absolutely. After this study, the hospital approved for us to purchase 3 portable probes. So that's what our residents using right now. The portable probes quality, image quality is becoming really, really superb. Very close to the laptop machines and the other bigger ones. So, but we connected all these probes to our data network so we can save the images. So the most important thing is whatever machine you use, you need to save the images during image acquisitions and do interpretation lately. And as Dr. Hari mentioned, all these images should be reviewed in the future for feedback, because the problem is when you're a new trainee, you don't know what you don't know, so you can make mistakes, and there's no way you can learn except by saving your images and review them later with experts, and have some sort of quality assurance.
Excellent. Dr. Omar Dura, you want to ask something? I let you to talk. Please go ahead.
Thank you very much, Harry, for this wonderful webinar, and thanks for all the experts that have spoken. My question is for Dr. Bergara, and I know you're a big proponent of the EASY protocol. Is the one view an okay view, since a lot of protocols are dependent on more than one image? And what's your go-to view if you're unable to get a subcostal or if the patient has a poor window? Thank you.
Thanks for this question. You know how much I love the subcostal view. So the answers is one cardiac view. We just had a study. I didn't have time to show it. If you get a good quality one cardiac view, you still can utilize that view in interpretation. You don't need to do the entire examination, but you have to use it in conjunction with the other systems ultrasound. That's the inferior vena cava to look at the preloading conditions, and the lungs to look for pneumothorax, pulmonary edema, or pleural effusion. So if you do that, and that's basically what is the EASY exam, which is echocardiographic assessment using subcostal only view. Now, in a lot of our cases in the ICU, sometimes it's difficult to look at the parasternal and the other images because the lung is overinflated and covering the heart. In this situation, when your patient is on PEEP or have issues with mechanical ventilation, the heart will be pushed down and you can actually see it better. But in case if you cannot get the subcostal view, then the next view I usually recommend is any of the other views. But what we do is we go to the apical, modified apical, between apical and subcostal. So in this area, when your patient is laying supine, you can have an apical view a little bit more medial than the apical, or you can use the parasternal, as long as you use it into context. And again, don't do just single view of the heart without looking at the other systems at the same time, and save your images and get some feedback.
Thank you. I would like to thank again all the speakers, giving your valuable time on the weekend, sharing your expertise, amazing talks. And this is the first complete focused webinar for the World Regional Day. So we started the path. So hopefully it will go a long way, and many people would have been benefited. Everything will be recorded, will be available from ASRA and ESRA. So if you missed something, don't worry, you can always hear at your leisure. Thank you so much. And I will leave the closing remarks to Liz and Eleni Moka. Thank you all.
Thank you, Harry. Excellent panel, excellent talks. I have to admit that I have to listen to them again through the recordings because it has been extremely busy here. But I truly enjoyed all the lecturers, excellent presentations, and very nice discussion. It was a great opportunity to meet all together, even virtually, and exchange opinions in very hot topics in our practice. Thank you very much.
Thank you, Eleni. Congrats once again. Great day. It is like a festival all around the world. If you see the social media, Facebook, LinkedIn, and Twitter, it's all about regional anesthesia. Until tomorrow or day, even the T20 match was not a discussion today. I'm a big fan of cricket. I was sitting here missing the cricket, but it is a festival of pain. But always think beyond regional anesthesia, point of care ultrasound. That is the main thing. I want everybody, be experts in focus, just not regional. Don't stop the buck there. You need to advance, move, improve the patient's care, help the patients. And if you are interested in courses, I told you, we do the amazing course, 1.5 day, the best course in the whole world. I'm telling you, I can tell, I can assure. Come in Tampa, Florida, you can enjoy the weather. It's in September 27, 28. And I again catch up in ASRA meetings. ESRA meetings in September in Oslo, Norway. Okay, see you all again soon. Thank you all.
Thank you. Have a nice day. Bye-bye.
Thank you, everyone.